I don't know. I think you do initial thing, and then we'll take it from there. I go to.
Good morning, everyone. May I ask everybody to be seated? Iekšā. Vilni, dzird mani? So good morning, everyone. Good morning, conference guests and conference speakers. My name is Zana Seaman, and I am coordinator of this project in local level. And I'm very pleased that so many of you have had this chance to attend today. And I would like to remind you, please keep your phones on silent mode so that we can speak one with another without interruption. Also, I would like to inform you all that this conference will be recorded and will be translated on Zoom and also on the YouTube channel of Valga municipality. So if somebody would like after this conference to have the video of this conference, please let me know and I will share with you. So today we have guests from ABR, Katriona Millen, and she's also working for B Solutions, who is the main project leader, I would say, for this research that we have accomplished. And then we have Martin Guillermo Ramirez, Secretary General, Association of European Border Regions, and Ricardo Ferreira, European Commission DG Regio Border Focal Point Coordinator. Then we have got two research ladies from Riga Stradiņš University, Daiga Behmana and Alina Dudele. They have done really great research and they will introduce you all with this research. And from our town side, we have Vilmars Vesingi, sorry. And he will share the opinion of our citizens. Thank you very much. And I will give word to Katriona Millen now. Thank you.
Thank you, Zana. And thank you to Zana particularly and Tom's for all of the work that has been done to organize today. We're very pleased to be here. It's my first time in Latvia and in Estonia. My name is Katrina Mullen and I work as an advisor with the B Solutions project, which is a project delivered by the Association of European Border Regions. Our Secretary General, Martin Guillermo, is here to speak with you today as well. And B Solutions is funded by the European Commission DG Regio Border Focal Point. And Ricardo Ferreira, who's the coordinator of the focal point, will also talk to you today. So we'd like to give you a full picture of the importance of what we're here and you're here to discuss today, and the importance of the creative solution finding that this project has been about for the citizens of Valka and Valga. I would first like to introduce, to officially open and welcome you. I hope I have this pronounced right. Gita Avote, who is the chairwoman of Valka Municipality Council. Gita, would you like to come and open? Thank you.
Labrīt, cienījamie konferences dalībnieki un organizatori. Man ir patiesas prieks jūs redzēt šodien šeit pie mums Valkā un, protams, liels gods atklāt šo nozīmīgo konferenci. Esmu pārliecināta, ka mums šodien būs iespēja runāt un arī dzirdēt speciālistu redzējumu un risinājumu par tik būtisku un svarīgu tēmu kā veselības aprūpes pakalpojumu pieejamība. Latvijā ikvienam cilvēkam, neatkarīgi no vecuma, tautības un sociālā stāvokļa, ir tiesības saņemt kvalitatīvu, laipnu un cieņpilnas ārstēšanu un aprūpi, kā arī iegūt informāciju par medicīniskās palīdzības saņemšanas iespējām. Novēlu mums šodien spraigas un interesantas diskusijas, iegūt jaunas atziņas un rast risinājumus nākamajiem darbības soļiem. Lai mums visiem vērtīga un izdevusies diena. Paldies!
Thank you, Gita. Our second speaker is Deputy Vilmars Vesingi, who is known to you all and who is a member of Valka Municipality. And I know from the perspective of the Association of European Border Regions, we were very glad to find Vilmars because we knew of this case. We knew that there was a potential solution to the obstacle for access to services at Valga Hospital. And we wanted to find the person who we could connect with to help to trigger implementing solutions and exploring future solutions for healthcare access in this region. So we found Vilmars. Vilmars has been very influential in helping us to understand the situation in the region. So Vilmars, would you like to come and speak to everyone? So,
yes, that's me. Okay, good morning. I'm Vilmars Vesingi. I'm a member of council of Valka Municipality. And I was born in Valka. Specifically, I was raised for the six first years of my life in Valga. So I have seen the borders come down during my lifetime. When I was born in '94, people were transporting sugar through customs. And here, right now, today, we see the same borders being renovated, public spaces being brought up, and basically everything has moved forward, moved in the right direction. However, this question of the hospital, of healthcare access, is something that has moved forward. However, this is something that is critical, and one thing that we still need to work on for the service to be available for citizens of Valka Municipality. So, before I start, I would like to, for those who haven't been here before, who are here for the first time, I would like to point you to the map, and I will show you where Valga Hospital is. This is it. So for further information, just imagine how close it is, because in the middle of the map you see the Latvian state border with Estonia, and you can see that it's very, very close. But first, a brief history about our border town. So basically, as one city, it was founded in 1584. However, history goes back at least 750 to 800 years. But the town was divided in 1920 when the Latvian and Estonian states were established. And this was an interesting process on how to decide where to split the town. And the map you see in this room represents on the decisions they made more than 100 years ago. But in 1939 and later on, but after the Soviet occupations, the borders were relaxed, and basically it was functionally one common town until 1991, when the Latvian and Estonian borders were re-established. And then there we see the pictures of fences. There we see how the border area is heavily guarded by border guards. But this process goes on till 2004 and relaxes somewhat until 2004, when the countries join European Union, and it's a common area, and only some token border controls remain, and those are removed again. Those are removed completely in 2007, when both countries joined the Schengen Agreement. So since 2007, we practically have no border. People can cross over, and they don't have to show their passport to anybody. However, we are here for the hospital question. So I'm going to give you a brief history of the hospitals as well. So we have had two hospitals historically in Valka and Valga. If we look back in in further past, we have had small hospitals in one town and the other one. However, what we see today is the hospital building in Valka, which was built in 1965. And the hospital building in Valga, which was built in 1997. So it's actually a pretty new building there. If we go further in history, we see the demand for the service go down in Valka Hospital. And due to this, in 2007, Valka Hospital is legally made a part of Vidzeme Hospital. However, the service availability keeps going down, and in 2014, we see that the care unit in Valka Hospital is closed in 2014. So later on, after that, we see only a small number of services remain in the Valka Hospital building. So practically, we can speak of Valka Hospital as a functional hospital after 2014. It's more of a clinic, what we call polyclinica in Latvian, and I believe in Estonian as well. And basically that is what we here consider the end of our hospital as a hospital. At the same time, I will show you demographics later on, but Valga Hospital experiences the same problem. Number of patients keeps going down. Number of services available keeps going down as well. And in 2018, we see Valga Hospital maternity ward closed. And this was a big shock to everybody, because before 2018, there was actually this birth tourism going on. People from all across Latvia were coming to Valga Hospital, and a lot of babies are born. I actually asked our family doctors before this 2018, approximately 1/3 of children born in Valka municipality were delivered in Valga Hospital. So this was a big issue for both cities, that we have no maternity ward in our common town. So why is this happening? Basically, it's demographics. We see that since the restoration of independence from 1990 in Valka municipality and in Valga city, we have a 43% drop in population. So and this is mostly due to unborn children, and this is mostly due to migration of young people to other European countries and to center of Latvia. So what we are left of here today is a smaller aging population. So basically, a smaller market for healthcare services. However, a number of people who need them more than an average population would need it. So, and of course, population projections see this number going down even more. There's a similar situation in Valga. However, it's not so critical. And one funny, that's a funny, but one footnote here is basically we can't tell the actual number of Valka citizens because the number is skewed due to a lot of citizens registering themselves in Estonia. So there's better access to healthcare and to other social services if you are registered in Estonia, and even more so if you work in Estonia. So we actually don't know the real number of Valka municipality citizens. We have only our own projections that this might be 1,000 people more in the city and or in the municipality. However, we can't really tell. But let's say the projection is clear that it keeps going down. So what about options of healthcare? What healthcare options do we have? Like I said, we have the Vidzeme Hospital, or let's say I call it Valka Clinic. We have it legally a part of Vidzeme Hospital that is located in Valmiera, which is in Latvia the closest biggest big hospital. It's located 55.2 kilometers away if we take it from this building to the hospital building. And the next closest, let's say the other close hospital is in Smiltene, which is another town not far from here. It has smaller number of services than Vidzeme Hospital, and it's also 45 kilometers away. However, we have Valga Hospital, which is only if we take it a car drive from this building to hospital building, it is 2.6 kilometers away. But of course, it is Estonia. It's not the same country. So not to say it's different rules apply there. But however, what do we have left here in our own city, in Valka side of the town? We have in the actual hospital building, we basically have one floor for healthcare services. For general practitioners are taking in patients there. 2 more general practitioners practice elsewhere in the city. However, there's another severe problem here because there are 6 general practitioners and they are all over close or over 60 years old. So this is another problem we have in regions in Latvia. And I believe to some extent in Estonia as well, that we have healthcare specialists aging, not a lot of young specialists coming back to work in regions. So we may talk about hospital accessibility today. However, general practitioner is the first step of any healthcare process. So if we have no general practitioners here, we might be in deeper problems than just healthcare service accessibility. So what do we have here in this Valka clinic? We have several examination rooms. There are some specialists coming to the examination rooms to see patients. However, what we see there are long lines. And with examinations, usually people need examinations quite fast. So if we have a line of several weeks, usually it's not an option for a person to wait for this service here on the spot for several weeks if he has a problem today. We have around 10 specialists. It's a changing number over time, coming from Vidzeme Hospital to see patients either once a week, twice a week, or several times per month, or even less. Also, the number changes. Also, it changes what kind of specialists Vidzeme Hospital has available in general. And we have a trauma care center there that is operational daily for small stuff like cuts and headaches and so on. That is basically this lowest level of healthcare lowest level of treatment is available daily in Valka clinic as well. And we have an ambulance on standby. There's an ambulance support point in this building as well. So, but what we see here, actually, it's basically economics. So we have low demand. So it's understandable that the service keeps going down, because at some point the number of patients is so low that it just doesn't make sense for a specialist to come for more than several hours per week, or more than several hours per month. And if you try to find a specialist who wants to come here and work from Valmiera, which is 50 kilometers away, spend time to come to Valka clinic and see patients, it's actually hard to find such specialists. I think our colleagues from Vidzema Hospital can say the same thing. So basically, we have reached this point in Valka clinic that we reached this point many years ago, actually, that we have a low number of patients because of demographics you saw. So there's some sort of line that basically doesn't make financial sense, and it's impractical to run daily services if they're not on such high demand. So that's why we have Valga Hospital, and that's why it makes sense for us to have Valga Hospital in our common twin town as a main option for healthcare services. However, as you know, it's in a different country. Even though it's 2 kilometers away, we only have several schemes set up that are these services are available at least on the same level as they would be in Latvia. So as I told that we are in EU, we do have all services available for Valka municipality citizens in Estonia. But we have this according to the EU directive, basically on the same kind of way that we would have a hospital available in either Portugal, France, Italy. So basically the same rules apply here. So what does it mean? It means the person can get a healthcare service and then gather all the documentation he gets from the healthcare service and give this documentation to our Latvian National Healthcare Service and get a partial refund of what the person would have saved if he would have gotten the service in Latvia. Of course, the Latvian National Healthcare Service recognizes the situation here that the hospital is 2 kilometers away, and it makes sense for us to go there. So we have let's say a fast approach system set up from 2020 that people can get services and can get the refunds faster than usually. NHS in Latvia knows what kind of documentation can come from Valga Hospital, and they are faster to work with this documentation than they would with any other hospital in Europe. However, patients are not very keen on using this option. I hope our researchers will give us some reasons why this could be. And basically, we have several people only a year using this option to get a partial refund after using Valga Hospital services. Basically, the good news, the best news we have from all of this situation is that we have ultrasound and X-ray services for free for Valka municipality citizens in Valga Hospital, and this is a special agreement that was made in 2002, and it's open till 2026. And it's basically a system where Valka area general practitioner can give a special paper to the patient, and he can with this paper he goes to Valga Hospital and gets ultrasound and X-ray services for free, and this is very popular. So we see one option that is heavy on the paperwork, not being so popular, and we see another option that is zero extra paper for a patient. And we see this very popular. I will show you in the next slide. Also, a note about emergency care. Of course, if we have a ambulance in Latvia, in Valga, and the ambulance in Estonia, it would on the surface make sense if we have a person with a problem that he needs to call an ambulance. It would make sense for the patient to be brought to Valga hospital, which is only 2 kilometers away, or more if you're somewhere else in the Valga municipality. However, this applies only if you have life-threatening injuries. And so if you have like some more regular, like a broken limb or some situation where you need an ambulance, if you call a emergency line 112, they will most probably take you to Vidzema Hospital, even though closest option, especially with free X-ray available, is still unavailable for patients who call an ambulance in Valga. However, if patients can make themselves, can somehow get to the hospital themselves, they can always claim that they have sustained an injury in Estonia. So they get free healthcare, free emergency care if they have a European health insurance card. So this is again something that is available all across Europe. If you have an emergency in any European country and you have this EVA card, you can get free emergency care, and you don't have to pay for it yourself. And the states later on deal with the paperwork. So basically, we have this option here as well. If a person gets an injury in Estonian territory, of course. So yeah. But about this ultrasound and X-ray, so as I said, it's very popular. And once I show you these next numbers, I believe you're going to talk about them as well in more detail. I would keep in mind we're talking about a small population of 7.5 thousand people in our municipality and 4.5 thousand people in our city. So basically, this X-ray and ultrasound has been used more than 1,400 times since this scheme was set up. The best year to look at is 2023 because we have full data for a full year. But of course, this as the information about patient experiences and availability as the general practitioners keep getting more information, they keep suggesting this service more and more to people, and this number keeps going up every month. So we have 956 people using let's say correctly, 956 times of use for X-ray and ultrasound services by Valga municipality patients using these special notes from the doctor so they can get this service for free in the year 2023. So for all of the period, we have this number that it costs for the Latvian state, because as I said, Latvian state reimburses this service. It costs less than 24 euros per one time per service. Of course, the price of the service differs on what kind of service are you getting, what kind of X-ray or USG picture are you making. However, we see this number 24 euros per one time as not a high number. So in total, in 2023, these 956 times cost only 23,000 euros for the Latvian state. So let's each of us think: is that a high cost of healthcare service availability for such a high number of people? Because 956, if we consider that some portion of this number is repeated service by the same persons, this would be approximately 10% of Valga municipality residents who have needed USG or X-ray research done in the year 2023, and they have gone to Valga hospital. So we see here that as a extremely high number. And maybe researchers can later on try to say if this is a proportional number of what people would use in any situation in other Latvian places where services are more available, or is this like some excess number of residents that have gone use the service because they couldn't do it before? So we have this. I would like to end on this slide with X-ray and ultrasound as a example that once you have a system where people can get the service either for affordable price or at no cost at all, with no paperwork they have to deal with themselves, people will go, and we will see the level of let's say the level of how we could call the health of the society go up. The costs connected to unavailability to work, to healthcare problems, this will go down once we have patients actually going and receiving the service. So this is not only a problem of being able to go physically to a hospital. This is also a problem of how easy it is and how actually available it is. Okay, that's it for me. Katrina, please.
Thank you, Bill. First, I just on a personal note, was very yes, we have to find the other presentation. Thanks. I just wanted to say when I think it's important also to acknowledge that particular experience that people who've grown up in border areas have. And I was just listening to Vilmar's talking about having been born in 1994 and seeing the borders change in this area. And I'm also from a border city called Derry in Northern Ireland, on the Northern Ireland border. And so our border was drawn in 1921, and our hinterland is 1 kilometre away. Derry is now outside of the European Union, unfortunately. But we still have huge connections. We always had family connections, a bit like the Valga thing. So for me, there are a lot of similarities in how the people move across the border here, even including not being able to tell how many people actually live on one side of the border or the other. We also have that issue. But I think that's also common to borders everywhere. But I think it's also very important to acknowledge the things that European Union membership has done for border regions. You know, I remember we grew up when I was growing up. I was born in 1973 in Northern Ireland, so I grew up through the conflict. So we had 2 checkpoints everywhere. We had a customs checkpoint and we had a military checkpoint. And in 1994, after 1994, our military checkpoints started to disappear, finally disappeared after 1998. And the customs checkpoints disappeared with the single market. And we also had a freedom of movement arrangement, a little bit like Schengen, called the Common Travel Area, which predated Schengen. But those 2 things, the single market and the free movement of people, create possibilities for border regions to thrive and grow and be places where people can live and be healthy and help to contribute, release their full potential for national economies. So when we're talking about healthcare and cross-border access to healthcare and the impact on national economies of border regions that function properly for all of the people who want to live there and work there, we are talking about very important socioeconomic and political issues. So I just wanted to say thanks, and also just to sort of declare myself as a border person. I don't know if anyone watches Netflix, but there is a comedy series on Netflix which is set in my city called Derry Girls. So anyone who's from a border with a sense of humor will probably enjoy watching it. Now I'm going to talk about the really serious stuff, which is healthcare mobility and patient mobility in the EU, to set the scene for the discussions today, which will be the substantive presentation by Daiga and Alina of the actual research on this region. But just to share with you some of our perspectives from ABR's perspective on cross-border health. For us, health is one of the major priorities for the European Union and for member states as we are. We've just come out of a pandemic. 100 years ago, Europe was coming out of another pandemic. We have major realization through the pandemic of the power of health and also the power of health status of the population, because those regions where people had poor health status, where there were more long-term conditions, shorter life expectancy, in those regions, people suffered more during the pandemic. And we have a responsibility to take the learning from that pandemic for the next generation and for ourselves, just to recognize also the people who died during the pandemic as well. So we're in a very important time to be talking about cross-border health and about health in border regions. During the pandemic, AEBR did a study for DG Santé, which was actually a part of the evaluation of the what's called the Cross-Border Patient Care Directive, but the full name is the Directive on the Rights of Patients in Cross-Border Healthcare. So we did a study on 4 different cross-border regions and looked at patient mobility issues in that. And we also produced a report and recommendations. The link to the report is here. We will share Zana will share the presentations from today with you, but I would recommend anyone interested to go and look at the recommendations of that report, because those recommendations relate to how border regions can create good conditions for cooperation and for health improvement of their citizens. So we wanted to share that with you, and also to point out that it's a very good reference tool for planning, for example, Interreg health projects, which I think you can have an opportunity to do in this region as well, just to look at how best practice can be built into what you're doing here. Just to say a little bit about what the COVID-19 pandemic told us about the health of our systems in border areas. And this again is from the research that we did. We know, for example, the pandemic took everyone by surprise in some ways. Different countries had different public health directions at the time. In some cases, we had emergency patient transfers. Ambulances couldn't cross the border because of lockdown, because of border closures. All of that learning and all of that chaos in the first 12 months of the pandemic became replaced by more operable and more workable arrangements. But we were interviewing people in border regions in the middle of this chaos. So we had people from hospitals saying, 30% of our nurses couldn't get to work this week because the border got closed, because they live on the other side of the border. And the other percentage of our workforce are living out of the boot of their cars and sleeping in their cars in case the border gets closed, so that they can come to work the next day. So all of these things were going on. Hospitals were trying to provide safe care for people, and you can't provide safe care if you don't have safe staffing levels. We know that there was capacity in border regions to provide bed spaces, for example, in emergencies. In some countries, for example, in France, because the protocols weren't in place, patients got transferred within the country, maybe hundreds of miles inside their country, instead of being transferred 2 miles, 10 miles across the border to somewhere closer to home. Again, regions and health systems have looked at this learning and are starting to change it. It's very important that we do embed the learning. As I have said before, I think that's actually an incorrect stat on my slide. I apologize, Ricardo. It's 30% of European citizens live in an EU border region. So the right to health is very important. If we are to give meaning to cohesion and integration at a European level, health is one of those crucial areas where we can demonstrate that that can work for citizens. That also involves working at the level of central state administrations, working with the regions, multi-level governance. So looking at the territory, looking at place-based partnerships that involve the national and the regional and the local stakeholders to make things work properly for health. Co-designing solutions, which I think today is the beginning of a conversation for this region, to be able to co-design and all the agencies work together and understand how they can contribute to innovation that works for them, works for their objectives, works with their concerns, but also works for the people on the ground. In general, you understand the cross-border, the challenges of cross-border healthcare cooperation. I don't need to tell you what they are. I do want to tell you that they're experienced in every border region in Europe in different ways. There are different versions of the challenges. We know it's complex. We know it involves working with different systems, different administrative procedures. It involves understanding the other. It involves understanding the system that is next door. So you have to understand the neighbor. You have to understand how the neighbor works, and they need to understand you. When you understand that, then you can work together. Excuse me. There is also a tendency with national systems to concentrate resources on the capital cities. Yes, of course there is. However, the cost to the state of delayed intervention and delayed access to services for the citizens who are further away, or the citizens who are in rural regions or in depopulated regions, that ultimately ends up being a cost on the national system. Now, if the national systems look at border regions and look at maybe that they have 50% of the solution and their neighboring country has 50% of the solution, then you're creating a new template for being able to lever and provide services to your citizens in a way that you're sharing the costs with the government of the citizens of the whole cross-border region. So there are different ways of thinking about this, and there is a need for this kind of creative thinking at the centres as well as in the regions. But the regions have an important role in providing the opportunity for the central administrations to explore innovative administrative solutions. This is about leadership in public administration. It's about innovation in public administration. Border regional authorities and municipalities have a key role in facilitating innovation in border regions for health. We know that the European Commission in 2021 produced a very important small document, but it was a very important communication which acknowledged the role of border regions as laboratories of innovation in European integration. So the borders are the places where European integration will happen and where European stability will happen. So border regions are important. They're important for the system. And they are places where people think creatively. We all know border people are very flexible. We think creatively, we work our way around problems. That is a huge asset when it comes to dealing with the challenges that Europe's now facing, dealing with the post-pandemic health challenges that we have. You know, we not only have the legacy of the pandemic and the learning from how the systems were before versus how they need to be now, we also have large populations of people with long COVID, in some cases who are quite young. So we have additional population health needs. We have the need for integrated social and clinical rehabilitation. We have more disability. We have various things like that that we need to take account of. The key thing also when it comes to cross-border health is member states working together with each other, understanding how they can actually work in a way that's shows solidarity with each other, but also with the citizens of the border regions. If you've got a specialist hospital on one side of the border, for example, in trauma and orthopedics, you don't need another one 2 miles away. What you need to be able to do is send your patients to the specialist hospital. And that way, the specialist hospital in trauma and orthopedics will be able to attract consultants and doctors who want to come and stay in the region and stay at the top of their game because they have a large patient group to work with. Because if you're a surgeon, you need to be doing a certain number of operations every week to keep your skills up and so on and so on. So the issues of medical staffing for border regional health providers and health systems can be solved if you look at things on a cross-border basis. You can create feasibility where it doesn't exist if you just think in terms of the national borders. The kinds of challenges that everyone is dealing with is emergency care cooperation, workforce planning, recognition of qualifications, multilingualism, the issues with different approaches to reimbursement for healthcare expenses under the directive on the Social Security regulation. And we're also dealing with, again, because of the pandemic, longer waiting lists for elective care, for planned care all over Europe. We need to think creatively about how that can be managed rather than national waiting lists getting longer and longer and longer. Can countries work together to help each other with their elective waiting lists, for example? Can we have bilateral agreements between countries to help with that? And also then the ongoing challenge, which you know a lot about, is the right care in the right place at the right time. So the earlier intervention, the better. The right access to diagnostics more quickly, so that you can then be on the right care path for you. So all of those things are challenges and become doubly challenging in the context of cross-border regions. The assets that we have at European level that will help with cross-border patient mobility, they'll not provide the whole solution. They are part of the solution. The Cross-Border Healthcare Directive, which is the reimbursement for planned care. Again, that places the burden on the citizen, and Vilmar's talked about this. You can place the burden of administration on the individual patient to pay for their care and then apply for the reimbursement, or you can think pragmatically and organize the reimbursements in a different way, perhaps from national insurer to the hospital. So that's what we're talking about in this region. The Social Security regulation, again, usually covers emergency care, covers care if you break your leg in a particular country and present yourself at a particular emergency department, you can use your European health insurance card. But where you have a critical mass of people who want to use a hospital regularly on the other side of the border, there is an argument to say that instead of putting the burden on the patient, which can also be time consuming for the hospital in terms of reimbursements, it costs more in administrative terms, maybe thinking about the idea of a block payment from one system to the other system for a section of the population is a more efficient and more effective way of doing things. And that's what has been done already with the X-ray and the ultrasound. So really today is also about looking at how can that existing good practice be expanded for the benefit of the population and also for the benefit of the long-term gain, because there will always, if you delay care, if you delay diagnostics, you make people wait, you make people travel long distances, you make it harder for them to get to access their healthcare. There are always costs to the state longer term. It's disability costs, the cost of economic, reduced participation, people who are disabled because they haven't had an intervention early enough. So it's a matter of national competitiveness as well. And I think, again, that was the point that Vilmars was making. In terms of the assets that we have in border regions that can help, we have institutional partnerships. So we have healthcare institutions already working together. We have representation here from both hospitals in the region, in the immediate area. We also have very good, strong working relationships between the two municipalities. That's an asset. That is valuable. That has value. With things like Interreg and with cross-border cooperation programs, there's experience and capacity in the region for working on multi-levels on new solutions for border regions. So you're already engaged in the process of cross-border cooperation and you have an affinity with each other and you have the ability to work together. Those are valuable and they are valuable fertile ground for future solution finding. The Interreg program has been a crucial source of support for border regions to be able to test and trial new solutions. Interreg is not a substitute for member states properly financing their healthcare requirements, but what it can be is a way of trying out new things and having a period of time where you have some European funding paying for it till you work out if it works and work out if it's going to actually be something that you want to do in the long term. And then you have time to mainstream it. So the Interreg program, if it's used as a tool for making your systems more efficient and more effective and better for citizens, is a huge asset that can be used for healthcare cooperation. There are always governance obstacles. There are always going to be issues, for example, with clinical governance, safety of patient referral routes. If you have the relationships and if you have the trust between the institutions and the healthcare actors, you can make anything work. You can work out things. So the relationships of trust that are there are also a huge asset for this. The kinds of options for all border regions to cooperate and to create things that work for their populations. I'm going to show a few examples. I want to say as well, it's very important that you don't think of yourselves as behind on this stuff. Because very often every border region I go to, people think, oh, we need the examples from somewhere else because we want to be able to imitate that. Actually, you might be the solution for someone else. So you've got to think of it that you take the inspiration from the other examples, but you might create something very new here that other border regions will be inspired by. And that is the important thing. So I'm giving you examples, but it doesn't mean that they're the ones that you're going to come up with, but they give you a sense of what the possibility is. So in my region, again, remote border region, no motorway accessing it. It's like the top right hand, if you're looking at the map, it's the top left-hand quarter of the island of Ireland. No motorways, no railways, historical underinvestment, real issues with health status in the population because of the conflict and because of socioeconomic underinvestment, migration, all the young people went away. Everyone from my generation left. I was one of the few people who came back to work in the region that I grew up in. So an aging population, all of those things. Both sides of the border didn't have access to cancer services within reasonable reach. So if you lived on the Donegal, which is now the Republic of Ireland side, you had to travel 5 hours one way to do chemotherapy. So you think about that on a bus, someone who's traveling to access chemotherapy, feeling really sick, having to leave children behind or having to leave, you know, carers behind, needing maybe a carer to go with them, all of that stuff. The same, excuse me, on the other side, people having to travel again to Belfast for cancer treatment. Because, and this, the important thing was this was a political decision because patients lobbied for access to cancer services. It wasn't the two systems thinking, this is a great idea, why don't we share the costs of a specialist cancer center? You pay half, I'll pay half, great, we get, you know, we pay 50%, we get 100%. That was the solution. But the reason that it happened was because patients lobbied on the ground, women particularly, breast cancer patients lobbied for years. And they got political support for the development of what is now the Northwest Cancer Centre, which is one of the most fine examples of cross-border healthcare shared services in Europe. It's funded, it didn't have any Interreg funding. It was not used, it wasn't an Interreg project. So they didn't use Interreg money. They went straight to mainstream, recurrent, 50% funding, core funding for the centre from both the Irish health system and the Northern Ireland health system. And that has saved lives. It has improved the quality of lives. It has attracted clinical specialists from all over the world who wanted to come and work there because it was this top class, state-of-the-art, cross-border cancer centre. The other service that we put in place in my region was, and this is again important for the emergency care piece, percutaneous PCI, percutaneous cardiac intervention. Yes. I just forgot the term there for a minute. So if you have a heart attack, it's crucial that you have the intervention within a 2-hour period, 2-hour window for your outcomes. If you have to be transported by an ambulance 4 or 5 hours away or 2-3 hours away, that window is gone. So again, what we did was, it was a very simple thing. We put a service in place at Derry that served people from the other side of the border, which reduced the waiting time and the travel time by sometimes up to 70% for patients who would have had to go for emergency cardiac care. That service saves about between 60 and 70 lives every year since it was set up, because those people would have died if they'd had to go to the other centres of care. They were able to come closer and they got the intervention within the window. Those really simple things. And it only costs the member state 50% because the other state is paying the other half of it. So, but everyone benefits. Another example is the very famous example of Cerdanya Hospital, which is on the French Catalonian border. And Cerdanya has all sorts of historical challenges with recognition of doctors' qualifications between France and Spain, and then also the social insurance and taxation implications of employing someone from another state, cross-border work and cross-border labour markets in a health context. And Cerdanya are now looking at the hospital themselves, employing integrated healthcare processes for the employment of Spanish and French clinicians, for looking at multilingualism, but making their system being the sort of the black boxes inside the hospital. So, and we're going there in a few weeks to talk about that. There's another system in Gmünd Hospital in Austria, which is cross-border, almost serves 3 populations. So the Austrian, the Slovakian and Hungarian population. They again have an organization called Health Across, which acts as a facilitator for patients accessing cross-border care. They work with the health authorities in all 3 countries. They help with reimbursements. They help with block reimbursements as well. And they also do initiatives to promote citizens' information on available health services in the hospital. And they have also developed new services at that hospital to meet the needs of the populations. And it's basically 3 languages. So there are examples everywhere you look that you can take inspirations from. It's very important when you're doing cross-border cooperation in healthcare to think about the unplanned care, think about the emergency protocols, think about the emergency access, the unscheduled care, but also think about your elective care. Think about what can be done long-term for that planned care. There's also the idea of having specialists on either side of the border who complement each other and who can also work with family doctors and primary care practitioners to transfer some of the learning. So globally, we are moving towards integrated care and clinical care. So the idea of primary and secondary care not being these 2 separate things. The idea of general practitioners, GPs, family doctors, having some specialist knowledge for things like long-term conditions, so cardiopulmonary conditions, diabetes, obesity, frailty prevention, and then also having access to be able to talk to a consultant. So instead of the patient being sent around from one doctor to the other, the doctor calls the consultant and then can give the advice to the patient. So it's about how we organize that expertise. And at the moment, I'm also doing some work with Romania, Hungary on their cross-border planning for Interreg programs. And they're looking at how they will actually share clinical expertise and set up a clinical leadership network for consultants and GPs across the region to be able to not only cooperate on patient care, but also to build the capacity of the region to operate as a region of excellence in what it does. And again, it's far from the 2 capitals, but they do have expertise in the region that they can actually start to celebrate. And there is rurality and there are issues with, more accessible maternity care. Maternity care is a huge quality issue for the economy as well. It's also about lifelong health for women. If you support women's health, you support the health of the whole of society. So there are lots of examples, but I think as well, I know that clinical leaders and hospital care leaders, they know a lot of this stuff. It's just about giving them the conditions and the encouragement and some of the political support to be able to explore those solutions. And also then for the healthcare administrations and the insurance funds to understand how they can help with that. Because ultimately everyone is going in the same direction. It is about equality of health outcomes across our territories. It is about life cycles. It's about early intervention. It's about children's health, access to children's services, pediatrics. It's also about health and well-being for people with disabilities. And if you've got a disability and you live in a border region, you have additional barriers there in terms of travel, in terms of needing care, accompaniment, in terms of the cross-border healthcare directive. Maybe one system will reimburse you for some of your healthcare costs, but not all, so you don't go. And so there are these barriers that I would say the directive and the Social Security regulation are financial reimbursement mechanisms. They do not replace the need for looking at citizen-centered healthcare planning. They are tools that can help with the reimbursements of those things. But the citizen-centered healthcare planning on a place-based model must sit at the area of the border region with the different stakeholders, so the municipalities, local government, and the healthcare systems working together. In that context, then you can also explore things like virtual healthcare, virtual video consultations with consultants, looking at the issue of rurality and distance and digitalization, and looking at how can digitalization work for rural communities, for people with healthcare needs. Again, the pandemic led to a lot of innovation by necessity because specialists couldn't always see people face to face. So there was a lot of innovation that took place that can be used for the good in the future. So I think what I wanted to do was really just set the scene in terms of the options and the possibilities for healthcare cooperation. to emphasize that all border regions experience some version of this. Your version is the version that we're going to discuss today. And we're going to have, I have to say, very impressive research done by Daiga and Alina and colleagues. And I'm really looking forward to hearing about that, because that is the evidence that, I'm going to just find the screen now, one sec. That is the evidence that is needed. Resume slideshow. Yes. Okay, I'm good. That's the evidence that we're going to base the discussion of possibilities on here, and also that I hope you as a collective will take and keep in touch with each other and keep having the conversations. I'm also conscious that we do have some online attendees as well, who I can't see. I just saw them very briefly there, but I want to welcome them as well, from the Latvian Ministry of Health. So there are opportunities to explore these things. You have tools, you have reimbursement tools, you have Interreg. You've also got political support in this region for the citizens. That's a huge asset as well. On that basis, I'm going to move to the next item in the agenda, which is to introduce to you Martin Guillermo Ramirez, who is the Secretary General of the Association of European Border Regions. Martin will tell you about the history of ABR. He'll talk about the B Solutions Initiative. The thing you need to know about Martin is that he's multi-talented. Martin is actually a medical doctor by training. So that's why ABR is very, very interested in health. We've always had a really, really passionate commitment to health as a form of empowering border regional people, to remove the barriers, to releasing your full potential as communities, as people, as individuals. But Martin is actually a specialist in public health. He won't tell you that. That's why I'm telling you that. So Martin, and he's also a very dear colleague. So thank you. Go ahead.
Well, what Katrina forgot to say is that I always have the impression that I made a good contribution to the humanity not practicing medicine. So I think I'm more comfortable in this side. Well, it's very important for us. It's not, of course, we hope this is important for you, but it's very important for us to be here because Valga Hospital has been one of the drivers of B Solutions from the very start. We had a package of examples when we started to think about solving obstacles for citizens across borders. This was the idea. Do you have the same living conditions that citizens living in Riga regarding access to services? Clearly not. And this is happening all over the borders in Europe. So, and then we were thinking, should we start identifying obstacles for the complex architecture of policy making? No, we need to engage local politicians first in order to be listened, and then we have to be understood by the citizens. So we said, okay, healthcare. Healthcare is something that you cannot postpone. You cannot say, okay, this year I will devote to whatever, and next year I will devote to my health. No, health is what it is, and then we are fortunate that we live in Europe. So in principle, every citizen has access to most of the benefits. Okay. And then it's not the same than the United States, that you don't have money, you have troubles. But here, the problem is that not every citizen has the same opportunities, especially if you live in the borders. Then we started putting the example of the hospital in Cerdanya, which was a hospital created cross-border from the very start. So citizens in France and in Spain can go to this hospital without problem. But does it mean that they don't have obstacles? Of course they have. The citizens can go to the hospital. The problem is the staff, because it's a cross-border hospital that has been installed in a cross-border area where two national systems intervene. So the hospital is giving services to both systems. And there is the obstacle. For instance, the hospital is located in Spanish territory. So the French doctors theoretically should be able to work there, but they have to be registered in, I don't know what, registered in Spain, and things like that. So even the hospital in Cerdanya, which is cross-border, has obstacles. And then the other part of the coin was Valga, because it was for us, it was perfect to tell the story that sometimes it's very difficult to understand what ABR does, which is we are the Association of Border Regions. We try to make the life of citizens in border areas better by identifying obstacles or hindrances, etc., and then trying to solve it. Then the case of Valga was a perfect example for this narrative because it used to be one single city, then because of geopolitics and whatever, was divided. And then even with the European integration process and even joining Schengen, still they are two cities and it's not that easy to share services because, well, you know very well. So, and of course, it's we will be in 2 weeks or 3 weeks in Cerdanya, and then we will tell the story there from the other side. So having a cross-border hospital in Cerdanya means that they don't have obstacles? No, they have obstacles. Having the situation we have in Valga means that there is hopeless? No, there is a hope. And actually, this is the exercise. If we were able, after this process, to solve the obstacle in this hospital, so every citizen in any site is able to go normally to the hospital to receive the treatment, it's not only what we are going to achieve for the citizens in this area, it's also the message that we are delivering to other parts of Europe, because we have identified hundreds of obstacles on healthcare, on transport, on education, on whatever. And most of the solutions lie at the national level. The two nation states, they have to talk, they have to understand each other, they have to understand the cross-border reality, the citizens living in border areas where the services, the best services or the better available services are in the other side of the border. And this is not always understood in the capitals. Okay, Estonia, Latvia, they are not very big countries, so the capitals are not that far away from the border. But the reality is that they are. It's not a question of geography, it's a question of mentality. And this happens, sometimes we have the same attitude in the capitals of small countries, like in the capitals of Germany or France, because it's a question of the approach. So that's why we always are demanding a positive discrimination of border territories. We need a specific view of the border territories, because if we leave it like that, the departing conditions for the citizens in border areas are worst. And then the result is, as the young people leave, that we have brain drain, and we are condemning border territories to enter a vicious circle in which aging, brain drain will remove the opportunities for development. We would like people to come back to the border regions, but then they need to have opportunities. We cannot condemn youngsters to say, okay, you have to stay in your territory and then, sorry. No, you need to have opportunities here. And that's why ABR was created 50 years ago. ABR started praying in the middle of the desert because nobody understood very well what we were talking about. But little by little, with the contributions of the little experiences of citizens living in border areas, we were able to paint the picture of what is really happening in border areas. Of course, this happened before Schengen. So the EU was developing, new member states entered, the geopolitical conditions we had in the 70s, in the 80s, disappeared, more or less, let's say. And then, but even now in Schengen, we still see that there are many obstacles to solve. So, and this takes us to the point, why do we need a positive discrimination of border territories? Because even with the European single market, even with the implementation of Schengen, still, especially for the provision of public services, the logic is national. And then you have national realities which are sometimes not very compatible. And you have a portfolio of services in one side of the border provided by the Estonian health service, and probably the portfolio of services in the Latvian is not exactly the same. What to say about the prices, etc. All this creates also additional problems. We have the same in transport. It happens the same in education. But healthcare is so particular, and it's not only important to solve the difficulties for citizens to access to care, it's also the narrative, I told you. Politicians always are interested in what we are saying about healthcare. and especially in areas like here. So after very, I think, interesting steps made by border regions in Europe during the 70s, the 80s, the 90s, etc. Some 10 years ago, the European Commission started to make a reflection process in order to see how the territorial cooperation should look in the immediate future, contributing to the process of European integration. We are always saying in border areas, we are doing integration in a daily basis. Yes, but it seems that only we are aware of that. So we need the European focus is clear. In the European Union, it's very clear for them that if we are able to integrate better and better citizens across national boundaries, we will increase the level of trust. And finally, we will do a proper integration, solid, robust, from the very bottom. But in the nation states, it's not that easy. Sometimes they are not really aware of the reality in border areas. In other occasions, there is no critical mass of population in the border areas. And then the mainstreaming policies and politics are played looking at the capitals, at the big amount of citizens, voters, actually, taxpayers, small populations, rural in border areas. Let's say you are sometimes not relevant to move a government, but you are citizens and you have rights. So the Commission made, I think, a very smart exercise in 2015, a cross-border review in which I think it was very interesting to involve the stakeholders from the public sector, from the private sector, from the academia, from civil society. During 2 years, more or less, we were identifying and trying to find a minimum common denominator. We was a series of obstacles which are more or less being repeated all over the European Union, precisely because there is no fine approach when implementing national policies, taking into account the cross-border dynamic. And the cross-border dynamic is growing, is not an exception, it's becoming something quite usual in the whole EU. Actually, 1/3 of the European population live in border areas. That's why then the cross-border review identified 250 obstacles which were analyzed by different experts. Then the Commission also, in the communication of 2017, proposed 10 measures. One of them was B-Solutions, which is the one why we are here today. And even there was another element I would like to mention, which is a legal tool that could be put in place when the problem to solve the obstacle for providing healthcare or whatever across the border has to do with the incompatibility of two national legislations that they don't take into account the intersection that they have in the border. This tool has a long story that perhaps Ricardo will refer to it afterwards, or we can comment in the coffee break. Now there is a new proposal of this tool on table put by the Commission, and in the next months we will know if this will happen or not. Because these solutions cannot solve all the obstacles. We go obstacle by obstacle. So sometimes even there are obstacles that we don't know, because we need someone to be able on the ground to identify the obstacles, let us know. We see if this is really illegal or administrative, then we can allocate experts to, well, you know, the exercise that we have made for this case today. But in other cases, yeah, we don't know, or even we don't have the appropriate knowledge, etc. So it's this is a kind of patchwork with the B-Solutions we do here, there, but we need a general framework, legal framework at the European level, where the citizens facing an obstacle to get access to services or whatever in their home, even if it is at the border, that they are able to ask the authorities, in this case the European Union, to implement certain regulations or whatever. But at the end of the day, is the nation state who to have a European framework, legal framework to solve this type of things, we need the agreement of the states. And this is becoming hard. It's really hard. That's why B-Solutions is not only about solving a particular obstacle, but the whole package will show a picture saying, look, we have a lot of gaps. I have prepared a presentation that I prefer not to go through because it was perhaps too long, and I prefer to share with you these feelings. But the presentation is available. There you will see, there are, we have put several tables where you can find the which are the topics, the themes of that we have identified in B-Solutions? Problems related to language, problems related to healthcare and to mobility. These are the main issues. We have made tables with thematic, per countries, per obstacles. So you can see what is the type of revision we have done in general for B-Solutions. And of course, if anyone is interested, all these graphs, etc., are back with studies, articles, etc. We have a lot of literature that has been produced around B-Solutions, and I didn't want to overwhelm you with so much. No, because here the messages are 3 or 4. B-Solutions cannot solve everything, but can show that there is an issue that sometimes is not well perceived by the member states. On the other hand, B-Solutions can give hope to border areas, because even complicated issues like this one that we are tackling today could be solved. Let's see if we are able to do it. And even more was mentioned, wherever we have an area where a lot of work has been done in order to identify an obstacle and trying to find a solution, as it is the case here, this may provoke something similar in other border areas where they don't have this opportunity, but they didn't have the opportunity to identify. What I mean, sometimes there are obstacles which are not perceived by the citizens. I'm living in a border area, so it's normal that I don't have access to this service. If I were in the capital, I would, and then that's life. No, you should be able to get access to all services wherever you are living in a border area, in a mountain area, or whatever. And this is possible, but we can make it cross-border. Do we need 2 hospitals in Valga? No, we need 1 hospital, which is strong. So, well, let's manage together. And then we have examples like that all over Europe. So this is what we would like to solve together, the issue. And we would like to show this good news to the European Union. With very little efforts, especially from the financial point of view, we can solve a lot. It's only a question of political will. And of course, it's also a question of trust. So all of these are the keywords that we would like to develop. We are really happy to be here. I'm really looking forward to listen to the experts. I have gone through the draft report, and the solution is there. We only need to implement it. So here we are. That's why we are here. And of course, again, I would like to end up saying all the information we have produced is full available for you. In case of doubt, please ask. Don't keep anything in your pocket. It's very important for us to know really the perception of what's going on, because with this, we are not only learning how to recommend possible solutions or steps to get towards the solution, but also all this information can be extremely relevant to tackle the obstacles that can be found in other parts of Europe. This is a collective task that we are really happy to implement, but without your contributions and then afterwards, your pressure, whatever is needed, would not happen. So here we are, and please use us. Thank you very much for your attention.
Thank you, Martin. And as we have already said, all of the presentations from today will be sent out to you and available, and Zana we will liaise with. And we'll also maybe suggest some other resources that we can send to you that will help with thinking. We're actually going to take a short comfort break now before Ricardo and then the research. So it's 11:18, 11:30, 10-15 minutes, back here at 11:30 for the next section. Thank you very much.
And I would ask everybody to join us all to have some beverages and some tea and coffee at the end of the hall. Thank you.
Was okay. Was okay the approach. I changed it completely. I can see the faces. They are. Yeah, sure. Of course. We can. Yeah, exactly. Nicotine and coffee. So here or okay, because everybody will. Yeah. Okay. Yeah, but because it's full of non-mind.
I know. I think I have the mayor of Leipzig and the German ambassador to Ireland in mind.
Yes. For the PhD students. So then so this I'm there you would say so then yes.
Okay, we need to go outside right now.
Schwester? Schwester?
I think yes.
Yes. Hello. In speaking, yes. I'm a small man, so I need to put this down. I'll start. They are tired of hearing to me because they hear to me everywhere. So they skip to do something else. So for the next few moments, I will be speaking. I'll try to be quite fast because we all want to listen about the research that was done in the specific case, entering into the specifics of the present, of today's. I'm the strange guy here who is not a doctor, who doesn't understand anything about healthcare. I'm just a boring economist coming from a very gray place called Brussels. In trying to present you just a quick few elements. Because you have the screen, sorry. I was just pulling it down to be more visible. And trying to present you just a few words on the political whys. Why is this relevant for policy making? Why is there on the top of my presentation the symbol of the European Commission? That gray, boring place far away in the center of Europe. But before I go to Brussels, I like very much the introduction by Vilmars, looking at a map. And before being someone who works in Brussels, my name is Ricardo, I'm Portuguese. I was living for 15 years in a place like that, in the other extreme of the European Union, on the Portuguese-Spanish border. And I really feel at home here. We were a population of 12,000 inhabitants. It was not the same conurbation. We had 2 cities with a space in between, and the border it was not just one urban node. It was 2 different urban nodes very close to each other with the border in between. But I also had the issues of the bricolage administrative that we need to go through to have healthcare in depopulated areas. Bricolage administrative is the capacity to find a solution where you need to be very smart in such complex processes like the ones that Vilmars was presenting. You need to be very smart and very aware to have access to healthcare. And therefore, that's discriminating people because many don't have access to healthcare. I was living on one of the sides of the border. The hospital was on the other side. My daughter at the age of 2 or 3, my wife would kill me if I didn't know the age. My daughter at the age of 2 or 3 had pneumonia. She was hospitalized on the other side. So we went through all the process of the administrative burdens to find that operational. In the end, it worked very well. But the elements are there. The lack of access, the lack of efficiency. And this is the element of the why. We talk about, Vilmars presented clearly the depopulation of this territory, the aging of this territory. And one of the elements is the need to have public services. One of the elements of attractiveness of the territories is the need of having public services. I work in the European Commission in the unit dealing with Interreg. You know Interreg very well. In the city center here in Valgas, you have big posters about Interreg. Interreg is the funding instrument, trying to push for cross-border cooperation, trying to push for the best of each territory, even when the best is cooperating with each other. And that's the element we need to ensure access to the population, to ensure effectiveness of the services. We need to be capable to understand that map as a unique thing. That is one territory. The slogan you have by the border, one city, 2 states, is very telling. It clearly demonstrates what this territory is. One city with 2 administrative systems. Therefore, we need to be capable to find the ways to solve those, to link these 2 administrative systems. In looking at that map, I find one of my usual slides. Why is this? One person, wherever lives, should be capable to explore its territory to its full potential, 300 degrees around myself, in a given radius. If I am a pizza delivery person, I will deliver my pizzas until 5 kilometers from the pizza shop, regardless of the direction. That's the image on your right side. But then if there is a border, and with that border, we get those legal administrative border obstacles that prevent me from partially interacting, I am hampered. There is an element of discrimination. There is an element of reducing access to development of the territory and of the people. Why is the European Commission committed to this? In the Treaty of the Union, we have the recognition of the specificities of cross-border territories. We are pushing and we are committed for the development of those cross-border territories. Cohesion policy, Interreg, ERDF, are based on the trying to allow each territory to develop to its utmost potential. And we see clearly that in cross-border territories, because we acknowledge those border obstacles, there is a huge socio-economic potential. If we would be capable to solve 20% of the existing border obstacles, only 20%, we would have a potential of increased 2% of GDP in these territories. That's an estimation done in 2018. On your right side, you have an estimation done in 2013 by a different institution pointing to 3% of GVA. Do not make a comparison between the number because the numbers are not exactly the same. GDP and GVA are different, the methodology is slightly different, but it shows the range. It's quite interesting. This socioeconomic shows precisely this. European border regions are living laboratories of European integration. It is like Adriano was saying, the places where European integration and European stability will show, will develop. Why? What have we, in this context, what have we been doing? What are we doing? What do we want to push? Well, cross-border cooperation is almost seen as a synonymous for Interreg. We have been doing Interreg for 30 years. Interreg has been the funding instrument of our support. With Interreg, we have been financing cooperation. In many cases, we have been triggering cooperation. It was the fact that the money was there that led some institutions to get together and to find solutions. But it has also shown the existence of border obstacles, the existence of those little elements of incompatibility amongst two different legal frameworks. Technical standards that are not equal on one side or the other. Reimbursement rates that are not equal in one side or the other. Administrative procedures for accessing the hospital and getting access to the health insurance, and all of the other elements. This has led us to the conclusion that we need to provide support beyond funding. There are several policy documents there. The presentations are accessible. It's quite important to understand we have been providing support beyond these elements with legal support, political support, and technical support. In this technical support, we include this sharing and piloting. This is B-Solution. Some of you have seen B-Solution, some of you have practiced B-Solutions. The idea is very simple. With B-Solutions, what we want is to show that border obstacles can be solved by helping some of them from a very bottom-up perspective, looking at one existing obstacle, trying to support that obstacle, and this allows us to get a clear picture of what border obstacles are. Martin was saying, look at the best practices, but remember that you are also best practice. You are also setting up an example. We are using these examples precisely to have the capacity to develop new policies, to design new policies. So we have been providing support with these piloting solutions via piloting cases with B-Solutions. The second element we have been trying to is to create the legal tools for cross-border cooperation. What are these legal tools? And here I'm pushing the discussion to a more macro level. In some cases, we find that at a local level, between municipalities, between regions, there is the will to solve an obstacle. There is the funding to solve an obstacle in some cases. But frequently there is not the legal instrument to solve those obstacles. Therefore, we are trying to support the creation for the legal instruments that allow to solve those obstacles. And here we need the support from the member states. Here is where the stories from the regions should be heard at national level. The ministries should understand the specificities of Valga and understand that the tools being proposed are precisely to solve this type of very local obstacles. The purpose of those tools is clearly to promote a stronger development of your own territories at regional level. The purpose will not have any implications at political level on the at national level. For example, those tools that I previously listed, the example of EGTCs as governance structures, and more recently, the solution or the proposed regulation for facilitating cross-border solutions. This regulation would, when adopted, would create the procedure for a regional or local stakeholder, like the municipality of Valga, to have a legal way to propose one obstacle to be solved, to propose to the competent authorities in its country. Therefore, there would be the legal way for the process for the discussion to start. It's very important that from the examples of Valga, your national member states are here, that your member states hear these examples, and they understand that the regulation being proposed is precisely to address this local issue. It does not make sense not to allow this regulation to move forward, because it would only hamper even more places like Valga. Cohesion policy is also one of the elements. The solutions to border obstacles are helping to address, to better design cohesion policy, naming all the support, the changes we created in Interreg with the Interreg specific objective 1 that allows for discussing on border obstacles. One final word on the facilitating cross-border solution proposal. I put the emphasis of my presentation on this specific topic precisely because it is an ongoing legislative process on which the different member states, including Estonia and Latvia, would have the need to provide an opinion. This is the proposal for the regulation that would allow on a voluntary basis. So the member state, when addressed with one obstacle, would always have the option to say, yes, we will move forward with a solution for this specific case, or no, we will not move forward simply because it is impossible, because it's not feasible, or because it's not in our political priorities. And it does not hamper any existing tools. It does not hamper that cooperation may be implemented with existing tools like the bilateral agreements between the member states. For the reference stays there, the potential stays there in the image as well. One last message. And here I'm repeating, and I'm just concluding fast because we want to listen from the research. Here I'm clearly repeating what Catriona and Martin have already said. In the end, promoting cross-border cooperation and understanding that map and understanding how to push for the development of that people in that territory is all about building trust and jointly building tools. Thank you so much.
Thank you, Ricardo. We've been very lucky in ABR to have Ricardo as our contact point for B Solutions within the European Commission. As you can see from what he said, he brings a very particular perspective as an economist to the benefits of these innovative cross-border approaches to solving obstacles for the people, for the whole of the territory, for the regions to be able to release their full potential back into the economies of the state. And that's why the health of the border regions should be an issue of extreme interest for member state governments, because it benefits everyone. We're now going to come to the substantive evidence that is the basis for what I think will be many opportunities for healthcare cooperation in this region, not just in terms of services. Not just in terms of services that can be accessed at Valgas, but also Can you hear me now? Okay, so the evidence that you're about to hear, which has been done by Riga's Stradina University, is the basis for not just patient access to Valga Hospital. It may also be the basis for Valga Hospital and Vicena Hospital and other healthcare providers in the region to develop services, both in the hospital and outside of the hospital, in primary care, in the community, looking at developing new models of service all of the people in the cross-border area benefit from. And I'm really looking forward to hear some discussion and comments on this afternoon. So on that basis, I'd like to introduce feedback. I'm going to go ahead and introduce in any case the team from the biggest university, led by Tiger Bimane, and with Alina Gula and Lisa Kursta, and between them, they have done a very comprehensive research on the needs and the opportunities for cross-border healthcare cooperation in this region. So I'm going to hand over to Tiger. There we go.
So, thank you for introducing, and our study was mentioned already several times today, and now we are ready to present. I think somebody has to switch on the microphones. Somebody is a Zoom. Yeah, so
I wonder if it are online participants, has someone got a microphone or a speakerphone? Yeah. Try again.
So, yeah, hello. Here you see our team, and I would like to say that me and Alina, we are economists as well. So, but we have a very long experience in the health system, like more around 20 years. And Alina also has degree in public health. So
And yeah, in parallel, let's say we are doing we are performing activities in our health system as well. So, but yeah, we represent Riga Stradiņš University, and our interest is, and our my specialty is health management and health economics, and Alina is health economics as well. So, and today, yeah, we will present the study, which was very, very interesting for us as well. And our interest actually in this particular issue was the reason why we agreed to participate, because yeah, it's a lot of issues around this, and also it relates to the situation how we build the sustainability of our systems in future, and this is our let's say main research topic. So the aim of this study was to prepare proposals for improving cross-border cooperation between Valka and Valga. And we had 3 tasks, and one was to assess the healthcare utilization in the Valka region in general and in particularly in Valga hospital. The second was to assess, let's say, access to healthcare for residents of the Valka region. And the third was to assess the indirect costs associated with suboptimal accessibility of healthcare services. So, and what we did, what were our methods? So, first of all, we obtained data from National Health Service and Disease Control and Disease Prevention Control Center on the scope and structure of healthcare services utilized in this region. Then we did a survey of residents of the Valka region to find out their opinion about obstacles for receiving healthcare services. Then we organized 2 focus groups. First with general practitioners, and the second with inhabitants. And then we did as well expert interviews. We conducted in Valga hospital, we were in Vidzeme hospital, Valka polyclinics, and Valka regional municipality, and also this emergency point at in Valka polyclinics. So if we go to the start the results, so first of all, we have to look to understand the context. And if already Vilmars as well touched the context, and which means the structure of the population in this region. And what we see that the population is decreasing. So from 2018 to 2023, it's 4% in the decrease, and the rate of decrease is higher than the average in Latvia. So, and then the prevalence of inhabitants at age over 55 is higher, is 26% higher than in Latvia in general, and the prevalence of working population is very much lower than Latvia as a whole. So this is indicator. These are very important indicators for further research. And then what the other indicator we looked at is premature mortality. And here we see that this premature mortality before age 65 in the Valka region significantly exceeds the relevant indicator in the country. And the 5-year average premature mortality relative risk index of the Valka region is 1.38 compared to Latvia as a whole. So although this premature mortality index is slightly decreasing, but still the indicator should be considered as high. So, so we see that this demographic picture is rather depressive, I would say. Then about the utilization of healthcare services by Valka region inhabitants. And here we obtain data from our agencies and as well from Valga hospital. So what is important it's very important to compare, let's say, the utilization numbers of services. And what we see that if we compare outpatient consultations with doctors per inhabitant, so per one inhabitant, here you see that in general, so the consumption here is lower. And sharp decrease was during the COVID years. But what we see is that if in Latvia the recovery in the health service numbers is, let's say, it's let's say, returning back to the pre-COVID years, so here it's much more slower. So it doesn't, we see that the utilization and the access, it doesn't recover so fast as in Latvia in general. So. Then, as you showed as well, we have to consider both. We have to consider this planned care and emergency care if we speak about the cross-border and services. But as we showed the context and the demographic situation, we considered that we have to look to the chronic patients because as we already showed that mostly so the population grows older, which means that here people have more chronic diseases, they are older and more with multimorbidity. And therefore we took main chronic diseases. We took two oncology diseases, we took second type diabetes, and we took asthma. And we looked the service utilization in these chronic diseases. How does it look? And what we see here, and as well, it was justified by the focus group with general practitioners, that actually general practitioners and primary care services are the main services here, because the specialist care is rather restricted, and therefore there is focus on GPs. And if we calculate the ratios, so what you see, these yellow bars are GP services, and these light blue are specialist services. And what we see is that there is a tendency that the proportion of GP services are still increasing, and but the proportion of utilization of specialist consultations is rather sharply decreasing. And if we calculate the ratio, so what we see that it's rather alarming, because let's say for specialist consultations, so it's only approximately half of the utilization if compared to utilization in Latvia in general. We even didn't compare with Riga or cities, but the general as a whole. And you see that the utilization of primary care is 1.4 in compared to Latvia in general. So it means that there is pressure on general practitioners, which was also acknowledged by them. Then later, Alina will also discuss more in detail about the results of these focus groups. But what I can already stress is that this is rather alarming, because we have to pay attention to the primary care here. We have to support their teams. We have to do much more so that GPs can treat their patients accordingly to nowadays standards. But you imagine if they are in shortage of diagnostic services, in shortage of examinations, how can they treat their patients? So this is alarming, and maybe this is also reflecting the indicator of premature mortality, could be. So, and access, yeah. So, and then about the utilization of inpatient services, this is as well rather preliminary. The numbers are rather small in absolute, the absolute numbers are rather small, but still what we see that the ratios of inpatient service utilization are as well rather high. For instance, for oncology diseases, it's even 2 times for C50 disease, for instance, yes. And as well, a little bit alarming for asthma, because you see that before, I have missed the years here, but it is before COVID and after COVID. What we see is that after COVID, actually, as well as a hospitalization of asthma patients has increased, and quite considerably, I would say 3 times. So, then, as it was already mentioned, but I would say that there is a good initiative which was already since March 2022, that NHS Latvia has agreement with Valga Hospital about paying for 2 examinations, which is X-rays and ultrasonography examinations directly. And what is, let's say, the basis? The basis is that NHS pays the tariffs which are established in Estonia, Estonian tariffs. So, and here you see it was already mentioned before that there is a need, and there is, let's say, if we see 1 year, total year, so about ultrasonography examinations, we see that it's more than 500. So here you see also the details of these exams, but what we see is that mainly it's, let's say, ultrasonography of the abdominal cavity and also of the arteries and veins. So it's in detail. So then about X-ray examinations, the same. The numbers are very similar, meaning that let's say in 2023 it was more than, it's around 1,000 examinations which were provided by Valga Hospital to Valga region inhabitants. So I think it's a rather considerable amount, and what we as well found from the surveys that people are really very, very thankful for this, and they appreciate this initiative very high. So, but then, so as you already mentioned, that the health system is a national exercise, and countries are very different in this, and unfortunately, I would say, we are in one economic unity, which is European Union, but we are very different in our health systems. And here you see as well the difference. And this is also a question for me, and this is a question for how we deal with the sustainability of our health systems. And here is one, I would say this is most important issue for health system sustainability, the health service tariff. So, and as we know from economics, if we let's say, put the tariff on the level under the cost of the service, so what does it mean? It means bankruptcy for the system, because actually you cannot you cannot work efficiently with tariffs which is under the cost of the service. And this is a situation in Latvia. And unfortunately, Ministry of Health is not represented here, but I would say that, let's say, from the economics point of view, this is the most crucial issue which has to be solved somehow. Or we have to have plan how to come to the tariffs which reflect real costs. And here you see the difference. And the Latvian tariffs for these 2 examinations, you see, they comprise from 35 to let's say 53% of the Estonian tariff. Means that actually the difference, okay, in economy there is difference between Latvian and Estonia, let's say, taking account the GDP of the country, on maybe the average salary, but not so much. There is not so big difference, so that the tariffs should be so different between, yes. So this is, I would say this is crucial, and this also is very crucial for cross-border these activities. So yes, and conclusions about the utilization is that, as I said, so we have to pay attention to GP services. We have to understand that GPs need consultations from specialists, and GPs need examinations. So later we will touch also Vidzeme hospital case, and as it was explained, that Vidzeme hospital has a branch here. It's Valka Polyclinics, which is a branch of Vidzeme hospital. But Vidzeme hospital is 50 kilometers away, and you saw the level of health service tariffs. And for Vidzeme hospital, actually, to come here and provide services is completely not cost effective. They cannot afford to do this. They have to buy technologies. They have to provide traveling for specialists. They cannot afford because it's under their cost. So the situation and GPs need support. They need teams. They need let's say help from other professionals. So this is somehow to be solved. So there is this negative structural trend. Let's say the access to ambulatory specialist care actually is limited, yes, and we see that the inpatient service, the need for inpatient services is growing. So then the utilization rate justifies the need for better, more timely access. And also there is increasing demand by the Valka region inhabitants to use X-ray and ultrasonography services in Valga hospital. Also, they are asking to broaden the scope of the services which could be provided by Valga hospital. And the expansion of the state-paid cross the services is currently limited by the different state tariffs. Because if we speak about the privately paid these services, or the services which are out of the scope of this agreement, then the citizens have to pay out of pocket. And if they get reimbursement, they get reimbursement according to the Latvian tariffs, and this is one of the hurdles for this cross-border cooperation. So, and then the next point is about the results of the inhabitant survey. So we got 212 responses, and thanks to the municipality colleagues, and it was done electronically in the social media and also on paper. So it was distributed through general practitioners' practices and also in the library. So I think that we got quite good response. So, and we asked like four questions. First was residents' desire to receive healthcare services at the Valga hospital, then factors that affect their willingness, and structuring, let's say, by accessibility factors, cost factors, and healthcare quality factors. Then we asked about services that residents would like to receive and the main hindering conditions. So, and the demographics of our respondents, we had 175 women, 36 men. Half of the respondents have chronic diseases, and 58 of the respondents have had already received health care services in Valga hospital within the last 5 years. And about the age structure, majority of our respondents were, actually it covered mostly the working age population. And I would say that also in the inhabitant working group, also the working age population was represented, And it was very, what we have to stress about children care, the, let's say, opinion of new parents and how do they feel here regarding, let's say, the possibility of health care for their children. So about the desire, so here you see the answers. Majority, more than 80% of the respondents answers that they would like to receive healthcare services at the Valgas hospital regularly, and also the same for their family members, so including children and their parents. Then, of course, about the reasons why. The ultimate reason is, of course, this geographical distance, because it's 2 kilometers no more from the house, it's like next door. And this is the main reason. Yeah, if we look, but on the other hand, I would say that inhabitants as well, evaluate the services at in Vidzeme hospital also very highly. And they say, we would be happy with Vidzeme hospital services, but because they appreciate that Vidzeme hospital has been, let's say, improving fast, let's say, previous years. But the problem is the distance and also the big waiting lines. But we feel that there is a certain maybe population which still would like to keep with Vidzeme hospital because it's language and other things. But about Valga, of course, what is that? What is the main reason? The main reason is that if a person from here has to get to Valmiera hospital, actually it is average is to take a day off, because it's especially by public transportation, then you have to change transports, then you have to wait, and then it is some waiting time in the hospital, then the service, and then you have to come back. So it's missing work, it's taking day off. And the other thing which I already mentioned, it's about the smaller waiting lines. And if you have to get, if you really need, as you mentioned before, that actually we cannot wait for healthcare services. So if we need healthcare, we have to have it. So, and then about the services, what residents would like to have, which services, and in the first is diagnostic examinations, and the second is specialist consultations. So these are two kinds of services we are speaking so all around. And then it comes elective hospital care, which yes, has to be. We have to discuss how to do this. And next is children care services. Yes, children, we should also take like a special patient group, because you know the distances here are very far. For instance, from Zvārtava parish to Valmiera, it's 100 kilometers. And if you have some problems with your child, it's very, very far to take your child if there is a hospital in 2 kilometers, or for Zvārtava, I do not know, maybe a little bit more. Yes, so next, the cost factors. Yes, the difference in the cost of services affects, of course, the choice of the place. We asked if really, let's say, the difference in cost of services, yes, they say affect. And this in Latvia is a very important issue, because the purchasing power here is not high. And especially if we take the demographics of that region, elderly people, multimorbidity, it means that the purchasing power is completely different than in, let's say, in Riga. Therefore, we have to understand that, you know, the system of these very low tariffs has stimulated the situations that doctors make their private practices, and doctors they are not willing to work in the public system. Even in Valmiera, there are specialists who Vidzeme hospital cannot let's say, provide some specialist consultations because specialists they are not willing to work for these public tariffs, and they make their private practices. And it means that you push the population, you push inhabitants into the private system. And the private system is developing here quite fast. And this is really a question what is our plan for the sustainability for our public system. And here you see that actually cost factor is very important. So, and if we compare, of course, the costs, let's say, if a patient has to pay privately for the cost of healthcare service in Estonia, which is higher, but still, if you deduct the transportation and your day off, so it means that also financially it's more, let's say, beneficial for a person to go and have a private service in Valga than, let's say, to go to Vidzeme. But of course, in Vidzeme, we discussed the conditions they would need to have their specialists here. And it's doable, and as we discussed, there are solutions, and later we could discuss the solutions. So, and then we asked about the quality. How do the respondents, inhabitants evaluate the personnel of the Valga hospital? And also we got very positive answers. So that first of all, respondents mentioned that Valga hospital offer a range of services that meet their needs. Valga hospital employs highly professional doctors, and also the hospital staff treats patients with respect. So here you see more than around 70% gives these positive responses. So, and concluding about this, concluding about the obstacles, what were mentioned by respondents. So, first obstacle is language barrier, and it is the most significant obstacle, and it means that there is a need to translate the medical records received in the Valga hospital. And then another question is about, do our healthcare professionals speak English? Can they communicate between themselves in English or Russian? So, you know, these generations change, and young generation doesn't speak Russian, older generation doesn't speak English. So still, this is an issue. Then what the respondents mentioned, that there is insufficient information about the services provided at the Valga hospital. And it was mentioned before that there, in the scope of a project, there was a care coordinator who was a Latvian in Valga hospital, who coordinated the care for Latvians. But it was based on a project, as I understand, and this is not anymore a case, but it could also be a solution. So then about the administrative procedure to receive reimbursement, but it's a general European cross-border regulation, and I think that we could not do a lot in a very short term. So, and difficulties in the continuity of care. Yes, I think this is a very important issue. It was mentioned mainly by doctors, also by elder generation, because, for instance, if you have, let's say, if you have emergency care and you are admitted to Valga hospital, then you are discharged. But then the question is what you do further, where you go, then you have records, you have to translate. But actually this is as well, I think the situation is improving, and there could be a solution how to provide this information better. And but then then the question of let's say about the referrals, how do our doctors can issue referrals for patients to the Valga hospital? So I think that there is some insufficient or misused information, but this was not clear. It was not clear for citizens, it was not clear for doctors. Let's say in Vidzeme Hospital, we had the issue that Vidzeme Hospital doctors cannot refer, let's say, inhabitant to Valga Hospital, that it can be done only by Valka region GPs or whatever. But then by our NHS, they said, no, this is not correct. And I think that this situation has to be, let's say, more clearly specified. Who can issue when and how and where. So, and those services which are not covered by emergency card or not covered by this special agreement actually have to be paid out of pocket. As we know, we have the private insurance possibility, and in Latvia case is that working age population usually have some private health insurance, which is mainly purchased by the employers. And it means that also what we discussed here is that maybe we can discuss, maybe this is a solution that also private insurance, which are on these cross-border regions, if they issue the policies, maybe they could cover as well the services on the other side of the border. So now I have come to quality study results, and I'd like ask Alīna to proceed on this.
Thank you, Daiga. I hope that you still have patience to to go deeper to our study and to see the results. Because as Daiga already mentioned, we did not only quantitative studies, survey, but also we did quite extensive qualitative studies. And qualitative analysis, we did organizing several focus groups. We had a focus group with patients, inhabitants, and we had the focus group also with family doctors. And in addition to this, we had several in-depth interviews with management of Valga Hospital and Vidzeme Hospital. And also we had a very long discussions with Valka polyclinics about the current situation. The focus point of the interviews and focus groups was to find out what are changes in the situation with accessibility of healthcare services for Valga inhabitants, how citizens, how doctors, and how professionals see the ways how we can improve this accessibility. Because as we saw from the previous part of our study, accessibility is not optimal. And the problem is that this suboptimal accessibility of healthcare services might be one of the reasons of excess premature mortality also at Valga city. So we asked specific questions: what has changed during the last 5 years? Are there any improvements or vice versa? And of course, we also wanted to get richer information about the barriers. As Daiga already mentioned in our quantitative study in survey, we asked already about the barriers, but we wanted to have deeper knowledge. What actually is hindering the access to necessary healthcare services? Here in our presentation, we put only very short results of our studies. In more details, everything is put in our report, but we put here the most important topics. And we divided all the obstacles to accessibility for healthcare services to 3 different parts. The first part is connected with specific features of Latvian healthcare system. So we also the construction and financing of Latvian healthcare system, of course, mainly impacts how citizens can get necessary healthcare services and what are accessibility, actual accessibility of healthcare services. And what we understood that Valga city inhabitants from Valga outpatient center can receive only very limited scope of services. And this is understandable also from health economic points of view, because the demand for healthcare services here is very small. And it is very difficult to create cost-effective system of provision of healthcare services for this small demand. But if we are talking that citizens could also go to Vidzeme and receive services there, the problem also connected with very limited financing of Latvian healthcare system is that also in Vidzeme hospitals there are very, very long waiting lists. And what also inhabitants told us during our focus groups that what they do, they usually also are searching around the Latvia where the waiting list is the shortest, and they go there because they need to solve their problem. So it's not only Vidzeme, they go to Madona, they go to Riga, they go anywhere where they can find the shortest waiting time. Then the very important and very expensive to our healthcare system problem is limited availability of timely consultation services for patients with chronic diseases. Because if they don't receive service timely, what they do, their situation is worsening and they ask for emergency care. And emergency care is the most expensive care in the system. So what we do in the system, we by not providing enough access to outpatient services, we increase demand to very expensive emergency care. So this is very bad for entire healthcare system financial sustainability, because we have to do vice versa. We have to improve access to outpatient services in order to decrease demand for very expensive emergency and inpatient services. And what we also heard from a patient focus group, from one patient, he told, well, I was calling for ambulance this year, well, maybe 8 times. 8 times patient with chronic disease who could be managed at outpatient level. It's very, very cost ineffective. Then the problem what we also found during mostly consultations and interviews with management, that also allocation of funding actually does not reflect population needs. So we do plan our financing for healthcare providers based on their historical performance, but there is an urgent need to revisit allocation of funds according to population's needs, to assess what are current morbidity, mortality of the population in different regions, and how we can best provide services in order to serve the population and not to go to very cost-ineffective services. So we have to manage entire system of healthcare service provision to decrease total costs, but at the same time to increase total benefit for the population. As Daiga already mentioned, one of the problem is our tariffs are not even covering cost of services. And I maybe not go deeper, as Daiga already mentioned, but this is one of the factors which is fostering development of private medicine here, and only limiting access of professional specialists to the provision of public healthcare services. Those were factors what we identified, which are not specific for Valga, but which are connected with entire healthcare system, but also, of course, for Valga inhabitants. At this slide, we have factors which are specific for Valka and specific location at the border. One of the very big problem is very low density of population and very small number of inhabitants living here. And here we have pressure from two sides. From the one side, number of inhabitants is all the way decreasing. But if you want to provide modern, technologically advanced service to the population, the cost of medical technology is all the way increasing. And therefore, from the one side, technology now can be very effective, provide very qualitative service in a very little, very small time. But in order for this technology to be effective, you have to have big number of patients to serve. And this is the difference, the different directions of those two trends, also limiting ability to develop very technologically advanced service here at Valka. But that's why, as Katrina told, we have to be very creative here at the border regions, and we have to find ways how we can, in a very effective, cost-effective way, ensure essential services for population available here. And this cross-border cooperation is one of the solutions what we can, of course, use. The problem also with this remote location is connected with necessary to travel, and necessary to travel not only for patients, but also for specialists. And if we look to entire healthcare system, the most expensive resource in the healthcare system is specialists, is healthcare specialists. And if we force specialists to travel 2 hours forth and 2 hours back, we are losing these 4 hours, half of the day, from his productive time. Therefore, if we are forcing specialists to travel around, we are losing very valuable resource in the system. And this is a very important limitation for the system. And we also here have to find ways how we can overcome this. Remote area also is connected with very limited public transportation services. And this is also one of the reasons why patients told that they have to have a day off to go to other city. And we will later see what are the cost consequences for this. So this remoteness add additional transportation costs both for patients and also for specialists. Barriers associated with cross-border issues, of course, already were mentioned by our experts, by Daiga, so they all are more or less known. First of all, it is a language barrier. And from the one side, we see, yes, this is a real problem, but from the other side, now we live in the world where artificial intelligence can do millions of things. And I don't think this language problem could be even mentioned as a problem. Just take the machine and everything will be done. The problem is with exchange of data medical documentation. Of course, in ideal world, we would have systems which are integrated, and all medical documentations produced, for example, in Estonia, already is seen by family doctors here in Latvia, translated, coded, with everything is done. But today we don't see this system. We don't have this system, but this is the issue where we have to put our forces also and to work around this, because technology is there on the place. We just have to implement and use this technology. Difference in tariffs already was mentioned, and I will not spend my time here. Administrative barrier also mentioned. in every focus group and every interview, but you know this also better than we do. And of course, yes, limited availability about the services at Valga Hospital. We saw also from previous part of our presentation that utilization of services at Valga Hospital increase. So we see that information is expanding and people now know that they could use the services and they do use. But still, we heard from all focus groups that there is not enough information about services, about the possibility to receive services, about procedure, how you could receive services. So, and this is also the issue where we don't even have to invest a lot of money. There are solutions what we can do today and now, and we could solve this problem. At the third part of our study, we also estimated costs associated with suboptimal accessibility of healthcare services for Valga inhabitants. And what we did, we made a very simple projection. So if patient from Valga has to receive outpatient service, he has to travel to somewhere, to Vidzeme, to any other city, to Riga. In order to travel, he has to use either public transportation or the car. And costs associated with this travel will be connected with direct transportation costs, either public transportation or gasoline, and time lost due to this necessity to travel. And for public transportation, you have to count for 1 full day. For private transportation, it's only direct time and time spent at the consultation. And in addition, now we are living in a world where we have to think about carbon footprint, and we have to admit that any additional travel will increase carbon footprint, and there are costs associated with this. And I will not go to the details of our calculations, but the estimation of additional cost burden for Valga region inhabitants associated with necessity to travel to receive outpatient healthcare services somewhere in another city annually is 985,000 euro. It is quite a sum. It is quite a sum of lost productivity, time. So the major part of cost is connected with lost productive time, with time spent for travel, for waiting, for arranging, so being not productive. This is one part of cost what we estimated. And one more part of additional costs is connected with premature mortality. We saw already at the first part of the presentation that at Valga region we have excess mortality, excess premature mortality. And if we calculate excess premature mortality and estimate productivity losses connected with those excess deaths, then only for excess mortality during 1 year, calculation made for year 22, the annual cost is 631,175 euro. So this is money which is lost due to the fact that provision of services is not optimal. One of the reasons. Of course, we can't tell that entire this cost is attributable to low accessibility of services, but this is one of the connections. And I think those numbers are quite alarming, and actually they are calling for immediate actions. So what are major conclusions from our research? First of all, as we saw, utilization of healthcare services are lower in Valgas and in Latvia. So there is insufficient availability of services. Majority of specialist consultation and diagnostic are available only outside Valka, but it could be also Valga. This absence of necessary specialist consultation and diagnostic services in close proximity is putting increasingly higher pressure to family doctors, increasing their workload and decreasing also the outcome of their work, because they are as many as they are, and they are working more and more. This insufficient availability also is associated with very higher burden of additional costs, both for premature mortality and also necessity to travel. And taking all this into account, what we definitely have to say is that increase of utilization of services at Valga Hospital could be beneficial for Valga inhabitants because it is not associated with additional cost burden. But the obstacles hindering now the higher utilization of services are, as we all know, language barrier, administrative, financial, and data exchange barriers. What we do recommend to do, we do recommend to continue provision of services at the Valka and thinking about extension of services which might be provided at Valga Hospital. But what I would like to stress also at this point, we have to be also creative from our side, and we have to develop fruitful cooperation between Estonia and Latvia, and not only sending our patients to Valga, but also creating possibility for Estonian patients to come to have services here at Valga. So developing complementary services at Valka and Valga, not competing one with each other, but complementing, so providing additional other services, thus increasing entire efficiency of this service availability and improving health of population of the region. What also we were thinking that maybe we have to create additional patient co-payment to cover the different in costs, so not to put this additional cost to state, but ask for patient to cover this change in costs for these specific services received in Estonia. But what we definitely want to recommend that we know the problems with service provision at the remote areas. And even for our family doctors, there are schemes providing different payment, taking into account low density of population in the catchment area. And we recommend that we have to think about extending this practice also to specialist services. So we have to, because today, this necessity to travel and cost associated with it are covered either by hospital or by patient. But it's not their fault why we put the cost to them. And there should be some schemes for provision of additional payment for providing service at the remote areas of the country. Of course, other thing is how we increase service quality and service coverage here at Valka. And here also we see that there are potentials. We have to think about creating of common practice for family doctors, and then maybe in common practice they can also have some more of diagnostic examination facilities to provide essential diagnostic services. And of course, what we definitely recommend, we have to think more about existing IT solutions, different kind of them. And as already was mentioned by experts, COVID trained us to use IT for provision of healthcare services. And we have only to further develop our knowledge, go further, because there are solutions. And the problem will not disappear. The problem will be only becoming more and more intense. So IT solutions should be exploited to overcome this problem. As Daigo already mentioned, and we had from the discussions, the coordinator could also be of help for provision of better service for the population. So this also should be think about. And also here we are talking about coordinator, not doctor, maybe even not nurse. This is coordinator. So taking also administrative workload from medical personnel. And we have to think about the improving of communication between specialists in Latvia and Estonia, and to go for more extended, more fruitful cooperation in different levels, because we are neighbors. Thank you.
Thank you very much, Becca and Alina. That was a huge amount of information. Is Elisa joining to speak, or just two of you? Is it just the two of you speaking? Yeah, okay. So I want to thank you for the research. I want to thank you for the analysis. We're going to take a break now for lunch. And then when we come back, I'm going to recap on some of the key questions that are coming out of the research. And we will have a discussion. We'll be opening the discussion to the floor. So I'll be calling and asking for some perspectives and reactions from anyone who would like to speak, but particularly I will be asking for comments and feedback from the healthcare insurers, including the Latvian Ministry of Health colleagues who are joining us online today. So they've said that they're happy to join in the conversation. So we'll add them and put them on the screen. And also then I'd like to hear from the hospitals and the perspectives on the ideas for new forms of cooperation. So there are two issues for consideration after lunch. One is, what are the next steps in creating more access and extending the scope of the current agreement for treatment at Valga? And then what are the other areas of healthcare collaboration that this region could and should take forward? And then agreeing all of the next steps in respect of those two areas. I'll maybe have a suggestion as well that we consider, maybe that you consider establishing a cross-border health steering group or collaborative for this region that allows for these stakeholders to come together more regularly to plan this out, because there's quite a lot there. And we're not going to answer all the questions today, but if we can agree next steps, that will be great. So enjoy your lunch and we'll come back afterwards. Thank you. To what? This?
Jā, dzirdi mani, dzirdi mani. 1, 2, dzirdi mani, dzirdi. Labi, ok.
Thank you for those who waited for us on Zoom as well. And hopefully you're going to join in the conversations as well.
Okay,
Now I'm
great.
giving word to Catriona.
Sure, thank you. Okay, so hi to everyone online, just to say hello. And we're going to try and have a participative discussion now. So I would like to open the floor to everyone who has listened all morning. And I'm sure you've all been thinking about reactions to what you've heard. But I think today there are probably two key areas that we need to try and reach some interim conclusions or next step agreements on. And the first is the issue of expanding the scope of the current agreement for the funding of care for Latvian patients at Valga Hospital. And I think I would like to start with some discussion on that by asking the healthcare insurers to give their comments, their reactions to what they have heard today, and maybe to give us some reflections on where what they think the next steps could be in the conversation around the scope of the contract. So on that basis, I'm going to go first to Andreta Livena. Andreta, are you there in the National Health Service? Hi, Andreta, thank you for joining. Thank you for your patience. Andreta, could I ask you, as the head of the International Department of the National Health Service, is this correct title? Okay.
Yes.
For the National Health Service. What's your reaction to what you've heard today? And what are your thoughts for the next steps in the conversation about the payments? And then I'm going to go to the Estonian healthcare insurers after that. So.
Yeah, hello to everybody, and thank you for this wonderful conference and wonderful presentations. And it was very, very interesting. I'm here from the, as somebody said, the very gray Brussels, trying to participate in several meetings at the same time. I think that mostly, and it might be just personal feelings here, I'm just very excited that this conversation has opened, that there was mentioned this also idea of finding creative solutions, because I think that we have had already so far lots of constructive communication. We have a very, very good communication with the Estonian Health Insurance Fund, and of course there has been the communication and cooperation with the Valga Hospital via the agreement. And of course, now because of COVID, there was, I feel like there was a little bit of an interruption, but right before COVID, when the procedure was set out for the reimbursement procedure, and making it more easy for the citizens of Valga, it seemed that we were really communicating very, very much, and kind of that it was, at least from my perspective, it was one of those creative solutions or some solutions that we were able to offer at that time that would make it more accessible. But of course, I also want to acknowledge the reality that that there are problems to access services. And so further conversations on all these different levels need to happen. Yeah, so I am very optimistic, I think. I am very optimistic, at least from the side of having these conversations. I also want to mention that I'm also here, yes, from the International Cooperation Unit, but I'm also representing the Latvian contact point for cross-border healthcare, and with our Estonian colleagues, we are already planning for a conference in autumn and September, where we were planning and hoping to look more at these cross-border issues and how, especially on the in the issue of providing information, because that was also one of the things which we heard, that that even though for us sitting in Riga or Brussels or wherever we are, it seems that there is there is lots of information, but again and again, you know, that is something which we realize that is one of the things which hinder people from receiving that information, because of course on the webpage of Valga municipality, I just checked last week, you know, there is the information about the reimbursement procedure and how exactly that happens, and, you know, and all the translation services and everything, and also about how access the services in Valga hospital. But of course, you know, when we also hear about all the demographics and everything, then maybe, you know, the web page is not necessarily where people look for that. I don't know. So I think that there are lots of good things to think, you know, how better that information can be provided. And of course, the cooperation and the communication between the different involved parties, so that because sometimes I have a feeling that, you know, there's a little bit of like, you know, there's this ministry or National Health Service, you know, and we are kind of like on one side, and then there's the Valga municipality on the other side. But really, I think that we all, in our different capacities, we want to find the solution. We want to find the solution, and so we need to kind of sit on the same side of the table and try to find how it could be done the best.
Well, thank you for that. I acknowledge that I know because I was involved in writing the report for the ABR DG Santé patient mobility study. So I know one of the recommendations was that the national contact points would look again at the issue of accessibility of citizen information on the directive, particularly in terms of the reimbursement processes. So it's very good to hear that the national contact points are starting to look at ways of doing that together and working together and working with regions. And I'm sure that there are, you know, additional ways that the information can be brought to citizens by working with the region and working with the municipalities. In terms of the existing arrangement, where there's a block payment for ultrasound and X-ray at Valga municipality, as the insurer, do you have input into that arrangement, or is that directly from the Ministry of Health to the hospital? Have you got experience?
The agreement is between the National Health Service and Valga Hospital.
So you have direct experience of how that agreement is working at the moment for you? Yes.
Well, I think it's working fine. I'm not necessarily involved exactly. I mean, I know the data, and you know, and also it was explained here, and also in the presentations, it was acknowledged as something very popular and very needed, and that many people are using it. Yeah, because it was in 2022, we identified that those two really critically missing services, and so then the agreement was concluded.
Mm-hmm. Okay. And of course, today we've heard evidence about additional critical services that, if they can be included in an agreement, will additionally reduce the drain on the system here. So I think, would it be fair to ask if you would be willing to engage in a conversation around what other services could be included in an agreement, given that we've seen the evidence from the university research team today, to discuss the outcomes of the research, and maybe with your Estonian partners and Valga municipality, a further conversation could follow up from this? Is that something that you would be interested in doing?
Absolutely. We need to talk about that, because I have already several times said that maybe it needs to become more concrete, because the two areas that I heard from the research was the first thing was the diagnostic services, which, I mean, just to expand those a little bit more, and that is definitely also something which from my perspective, I mean, I don't know exactly all the different, the health side of that, but from my perspective, as far as the logistics of like, not necessarily needing so much the language and things like that. I mean, that can be definitely something. And the specialist care is always something which is where the language barrier becomes really significant. And so then again, going back to those creative solutions and things like that. But I remember that in 2020, we were talking about, there are these different, doctors on the Estonian side speaking also Russian and English and things like that. But of course, we also know the reality that people choose most of the time to see doctors and speak to doctors in their own native language.
Yeah.
And one more thing I wanted to just to also mention what I heard in the research in the presentation was about also one of the recommendations was about all these IT solutions and the e-health data exchange. And of course, most of the research was done earlier this year and last year. But as of March of this year, so right now, the exchange in e-health between Estonia and Latvia is happening both ways. So it's e-prescriptions and also patient data, which is exchanged. And of course, that is again a separate conversation where specialists of the area would need to go into. But that is something which is at least partially the work has started there.
I think I'm going to bring in our colleagues from the Estonian health insurance side now in a minute, but I think you've made a valid point as well, which is that as insurers, as insurance funders, you can only really manage the reimbursement of services that actually exist and are in operation and on the ground. You're not responsible for designing the services, and you're not responsible for developing new forms of service that might deal with some of the issues like, patient language barriers and things like that. So I think it's accepted. We're not making you responsible for all problems, but certainly in terms of, I think, for Valga municipality to be able to have a conversation, for example, with the Ministry of Health, supported by with supportive environment from the insurers to say, this is working well. There's no reason why this can't be expanded if the will is there to do it. Then I think that would be very meaningful for Valga. So I think I'm going to take it from you that's going to be one of our next steps. I want to bring in, thank you very much, Andreta. Stay on the line. We might come back to you again, but that's been very helpful. And I didn't realize you were in Brussels today, so you're forgiven for not being here.
Yeah, no, it's true. I mean, this is the best you can get. Of course, it would be so good if we would actually have the representatives from the Ministry of Health, but me is all you get.
Well, that's been very helpful. Thank you. And I think again on the interoperability of health systems. I mean, one of the things that we're arguing that needs to happen in every border region that's interested in health, and this would be something that would benefit all of the stakeholders, including the NCPs who are trying to work on their own issues, is the idea of a cross-border health collaborative being established where all of these issues can be tuned into the region. So if the e-health collaboration is starting between the two countries, then let's look at how you can focus piloting of those kind of systems in this region, make it work really close to the border. But that's again where the regional stakeholders come in, and the hospitals and the clinical networks. So thank you, Andreta. I'm going to ask for someone from the Estonian Health Insurance Fund to give perspectives on your experience of things to date, and also to introduce yourself, please.
I was thinking of the microphone. Thank you.
All
right, seems I was talking to with a too low volume. So hi, my name is Marko Tähnas. I work for the Estonian Health Insurance Fund. My responsibilities are mainly contracting the hospitals, meaning the actual contracts, volumes, etc. I would add 5 simple thoughts to the discussion. So regarding Valga Hospital, I would say it's a rather small hospital for us. It's less than 1% of our contract volume. So it's less than 10 million euros. It's quite small hospital. What I would add on the table for Valga people on top of current procedures and diagnostics, I would add prevention on the table. For the sole reason that according to our numbers, every euro that we put into prevention generates 7 years of value. So at least for us. The thoughts I also had is regarding the specialists. As I understand, there are specialists coming from Valmiera hospitals to Valka Polyclinic. But at the same time, we are generating our next year's strategic buying plans, meaning that if the patient pool in Valga Hospital would increase, then we would need more specialists in Valga Hospital as well. And we are actually at this moment generating plans for the next 5 years. So this would be a valuable input for us if the patient pool would increase. Then almost the last topic, we are also starting or have started with the new payment models for smaller hospitals, meaning that it's not about the number of patients that are in the hospitals, but we are just funding 50% of the hospital needs without any patient, and the rest of the money comes with the patient. And the last idea I have is regarding the data. I know at least 2 companies in Estonia who is offering also for medical data offline, meaning that it's not saved anywhere. Online, meaning that it's actually, as happens, translation plus transcription. So the language barrier should not be an issue in 2 ways, from the data point of view and also from the actual interaction point of view. So we have, let's say, patients, more than 30,000 patients from Ukraine at the moment. We have 7+% Russian-speaking patients, a lot of students speaking English. So the live transcription plus translation tools that are available could be easily piloted in Valka as well. So these are the few ideas that I would put on the table.
And this is a translation tool attached to your the hospital patient record system?
It could be attached to any system, yes.
Okay.
Meaning that if Valka GP is using their own IT system, then it could be attached to that as well.
Okay, so that's there's opportunity for e-health collaboration. I'm seeing a whole Interreg program here already. So that's fantastic. Yeah, great. That's it.
We would be happy if Valga Hospital would have more patients.
Yeah, of course.
With Latvian money, of course.
Yeah. Well, again, can I ask you, I mean, if one of the steps agreed today is on top of the specific focus on the contract to establish a collaborative for this region, for these kind of things to be developed over time, is that something that as the insurer on the Estonian side, you would be willing to participate in?
In the past discussions, we have been included in the view of invoicing, meaning that we have quite advanced invoicing system, and Valga Hospital would prefer to invoice us and we would invoice the Latvian NHS. This has been one of the topics that we have been discussing.
Okay.
If the collaboration would expand, then I think it would be rather important. 23,000 euros is quite easy invoicing even in Excel, but the millions is rather more difficult.
Okay, so and this also feeds into the terms of an expanded agreement, which would be, can you do it in a way that's smart? If you're talking about more patients, and actually maybe that idea of the reimbursement happening at the level of the insurance funds is the right way to go, because it's less labor intensive for the hospital, it's less labor intensive for the patients, and it represents a building of trust between the 2 national contact points and the insurance system. So that sounds like a very fruitful kind of a suggestion. Great. Super. I'm going to, and I agree as well. I think it's a very good point, and it was in my head when I was listening today. Prevention as an area of clinical intervention, preventative medicine, preventative public health. Thinking about all those things when you're talking about the kind of collaborations that you can do in the region, and also to sort of, as you say, stem the flow from the patient with chronic conditions who used an ambulance 8 times in 1 year. It has to also be about the generation coming up behind who are able to live in a more healthy way for longer, and also helping people to manage long-term conditions. I'm going to, okay, so I think, is it safe to say that there will be a conversation about the contract? You'll take it forward. Okay. And then also, I think what we have is an interest in getting together in a more general way to look at all of these different opportunities for deepening collaboration. So the two health insurers are interested, Valga municipality is interested, we know that. That's great. I'm going to go now to I'm just looking at the list of who's here so that I can pick on people. I'm going to go, I think it's very important for the healthcare operators who are in the room to have a chance to give their reaction to what they've heard this morning, from the perspective of the hospitals, from the perspective of the clinicians, and from the perspective of the people who are trying to manage and design the services like outpatient services, and understanding what's happening underneath that in terms of the planning and the demand and the feasibility of things. So I'm going to start by asking Maria from Valga Hospital to give her reaction to what you've heard, and then I'm going to move around the room. So if you could please self-identify as someone who is working in the healthcare system, and please feel free to comment and speak. That would be great. Thank you. Maria.
Is it working? Yeah. Yeah, so my name is Maria Brause. I am the head doctor in Valga Hospital. And since Katriona mentioned that, COVID interrupted this process, I'm kind of glad that it happened, because I have been working in Valga Hospital only 1 year, almost 1 year. And I am very glad that it got interrupted, because now I have a chance to be a part of that. So, I'm from Estonia. I'm from Central Estonia, actually. I've graduated from Tartu University, but after that I went to Finland to specialize in neurology. So I have been living 11 years in Finland. After that, I came back, and I have been living in Estonia again 6 years. But I am working as e-doctor, as international doctor, cross-border doctor at this moment as well. Sometimes I don't have so many time anymore, but I do some work for Finland, and this is the e-consultation way.
Oh.
So this is very familiar. This concept doesn't scare me at all. It's very familiar to me, and we are thinking more and more about the IT solutions and the e-consultation. And this is one of the key points that we can use in this project as well. To provide more services, to provide more resources by doctors, to consult also the people from Valga side. As I am a neurologist, I, for example, worked also like this during the COVID time, that I would sit in my home and the patient would sit in Finland at their home, and we would make a rehabilitation plan for them. So everything is possible nowadays. So I'm very keen on this project, very interested. So from the hospital side, as I told you, I'm very, very glad that we are discussing this right now. Thank you very much for everybody. And Valga Hospital is totally in this project. So we are very, very interested. And the journalists also already asked me what is it there in for us, for Valga Hospital. Of course, Marko mentioned money. Yeah, money is always important, but I am a doctor, I'm not a businesswoman. So when Sanne and Vilmars came to me the first time in December, I also told them that my main interest is the people, to help the people who I see or even I don't see, but mainly the people who are right here in front of us. And it's very sad that there's a problem with traveling back and forth. It's not nice to the nature, it's not nice to the people. So yeah, this is very, very logical that the hospital of Valga will be the main provider of the health services. And we are also developing our services right now. And since we are here together, we can develop this also those projects and services together. So if I'm thinking about developing home hospital, for example, in the Estonian side, in the Valga side, so why not transfer it to the Valga side as well? So this is a concept that would solve those problems. For example, when we talk about the ambulance calling 8 times a year, if we have home nurses who are supported by the doctor, who can be at the Valga Hospital or in the distance somewhere in the center of Estonia, if it would be me, for example, then we can we can make a system that doesn't. Yeah, it's more effective. It's more effective, and it also is economical and ecological. Yes. So this is one of the things, and the other one is what also Marko mentioned. It's the prevention part. We are through this home hospital. We are trying to make everyone in Valga, Estonian side, their own personal health plans. Health plans that we will, well, there's a description what would you have to do, so you would avoid going to the doctor or hospital. If you do those things and take the medicine, you move, you eat correctly, and etc., then you will be healthier, and you don't need so much of those medical services that would also already treat you, not to prevent the situation. So if we do that, actually those numbers that the nice ladies who did the research show us, it's about 1 million we already will not to pay. Yeah, exactly. If you think about if people go to Valmiera Hospital and lose their 1 day at work, we can also, if you don't have to do that, either you're healthy or you go to Valga Hospital, you save this money. Or if you talk about home hospital, where the main clients are mostly the elderly people, we don't only save the health or money of those patients, but also the next generation who would go with a elderly mother or father to the Valmiera Hospital and lose their day at work. So the costs are even higher. If we are depending on the next generation as well, so they would lose their work day, for example. Yeah. So actually, if we make this system work, the hospital is right here. And we also deal with the prevention, then we would win a lot. Yeah. So I'm not thinking only about our, I don't know, profit or the business, but also about the people. I don't care what nationality the people are. I love all the people. So this is one way to help the people who are standing right beside us in the Latvian side, and we would provide the services that are useful for every country. And if, as I have contacts in Finland side as well, and we know that the healthcare system is very good there, or other EU countries, then we can take some good examples from there, but create our own example. So this is very, very nice. I have very many ideas how to do it. If we solve all those problems, then yes, we have a green light from our hospital. So thank you, and we will do everything that could make this project and system work. And I already see this group of people in nice summer days somewhere in the cottage, thinking, brainstorming, and going forward with this thing. So thank you very much.
You're very welcome. I got deserves a round of applause. I like the idea of personal health planning. The personal health plans is, I mean, if you could think about that idea of a target of every citizen of Valga and Valka having their own personal health plan, I mean, that in itself would be an amazing model for the whole of Europe, to say there's this place that every single citizen has their own health plan in. And the value of the personal health plans is that they do lead to prevention. You've also got things like social prescribing that you can look at in terms of that being an intervention. I know where I'm from, we now have a social prescribing model in place which GPs use and refer people on. It took a while. Yeah, it took, yes, the integration of the social prescribing and the personal health planning. So there's almost like a whole spectrum from early intervention to chronic disease management that you could look at for the region in a collaborative around new services and new ideas emerging. It's fantastic. And I'm always interested in the fact that neurologists end up in these positions, because I keep meeting neurologists who are in these border hospitals. So I must say you're part of the brains of the border region or something. I don't know. Anyway, I'm going to go next to maybe behind you from pētījuma Hospital. Yeah, or who wants to go next? Yeah.
Hello.
Whichever you're comfortable with.
Hello, everyone. So I'm representative of pētījuma Hospital. And as said before, I as well, and we from Vizima Hospital, we are really glad that for residents of Valga municipality, there is this possibility already to get the health service that we can't provide in Valmiera here in Valga. And actually, I have to say that already now citizens of residents of municipality of Valga are in more luxurious position than the ones in Valmiera. Because, for example, as per this agreement between NHS and Valga Hospital, the waiting time for ultrasound that Valga residents have is much, much lower than the one that people everywhere else in Latvia have to. So that's already a good thing. And even if it's possible to broaden this services amount of healthcare, so actually it would be a really good and even much better. So we from a hospital of Vizima, we would be really glad to provide some insight from our side as well. Of course, because of the all previously mentioned reasons, we can't really make the clinic in Valga bigger and get more doctors. It's really hard to even get doctors to get to Valmiera. So actually we would be glad to start a cooperation with Valga Hospital. Maybe we could find some way how to share specialists, share some kind of processes so that not only Valga residents gain something, but maybe Valga residents can gain something from our specialists as well. So I think that there is a lot of ways where we can work together, where we haven't yet, but we are really open for that. And yeah, let's see where it goes.
Great. Thank you, Christina. So we not only have the issue of the citizens in Valga getting access to Valga Hospital, we also have another hospital on this side of the border needing to work with Valga Hospital to look at the whole system and the ecosystem of service provision in the region. And that's another area that you can explore together as well. So it's great to have the two health services saying the same thing. So that's fantastic. Does anyone else want to comment and come into the conversation at this stage? Ilmars.
Yeah.
Sorry, hang on.
Okay. There's no echo, I suppose. Okay, so I have basically a comment for everybody, I guess. But first of all, I'd like to say thanks to Andreta, because she's been instrumental in every step of the way, at least for me, myself, communication with NHS and moving forward with any steps. She was here personally in this room when we tried to launch this eased procedure of reimbursements. But as it happened, COVID happened like few months after that. So this is basically why it stopped. And I would say that's our own fault that we haven't tried to, let's say, inform people again of this opportunity. We have only tried some minor things like republicizing the information and so on. But actually what it takes micromanagement with general practitioners, because they are the ones who make who the patients listen mostly to. So basically, if we don't convince them that this is a valid option for their patients are not going to believe me or somebody else who works in the municipality. We are not healthcare specialists. So general practitioners are key to any communication, any message that we're trying to convey to the patient. So it's just our own responsibility to work with the general practitioners in this. We have maybe it's just dynamics between politicians and bureaucrats. We have maybe accidentally made NHS sort of a boogeyman for patients, but it's not so. Like I said before, in the last few years we have had this agreement. It's like a big leap forward in cooperation. Many things have been done over the last 30 years, but this kind of access of free access to free procedures is something unprecedented, and the numbers speak for themselves. So many thanks to NHS for allowing this thing to happen. Again, for Vidzema Hospital, also in our society, they have been made also a sort of a boogeyman, that they're trying to take services away from Valka. But for me personally, I understand the economics behind it, and it just makes sense. It's not easy to keep specialists in Valmiera, to get new specialists. So for the numbers you work in Valmiera with, and the numbers we can, our citizens, the demand our citizens make here, it just makes sense that the numbers that you can provide here, they make sense. And for me, I believe that looking in the future, it is just reasonable to think that this Valka clinic here, it's not going to last for very, very long. So basically, for rational use of resources, it would make sense for Valga Hospital to cooperate with Vidzema Hospital for further provision of services from Latvian specialists. So that's like in the middle term, in 10 years, I think that just makes sense. Yeah. However, this thing you guys mentioned, the patient data integration between the two systems. This is something good. Basically, the only thing that remains is the language barrier, because the Estonian healthcare specialist will write his conclusions in Estonian, and even if the data is available to the Latvian specialists in our e-health system, it's still in Estonian. So it's still in Estonian. So there is this moment where automatic translations need to happen. And it's just, I think it's, again, a micromanagement question of working with GPs. Basically to tell them, where can you look for this? Where can you find this information? How it can be translated? And that's again a thing we have to coordinate. It's not going to be easy, but once it's done, once everybody sees the benefits of it, it can easily move forward. And it's just sort of small step in all of this. Yeah. So, but of course, this coordination group is a valid idea, and it doesn't make sense that we here work in an ad hoc way. Some activity from one person from one side, sometime from another. So this kind of coordination group needs to happen, like with people who work on the lowest level, because before a few years ago, before COVID, there was this. Let's say it's a bigger coordination group of politicians and higher level bureaucrats. That basically they met once a year, talked about all questions regarding Valga, not only hospital questions, decided what needs to be done in a year, met again in a year, and nothing had been changed in a year, because each state has other priorities, and if we meet once a year, there's no resources are allocated for this, then it's not going to happen. So basically, a lower level group that deals with these practical questions like translations and information exchange. This is definitely what we need to be doing forward.
I think it would be that coordination group.
Yes, most probably. I don't see any other way. Let's say I would love for somebody else to take responsibility, but
was just was one minor detail. Possibly it's not new information for anyone, but the issue of languages was frequently referred today. It's an obvious barrier that needs to be tackled, but indeed technology and solutions exist. Just to point you to one more solution that possibly some of you are not aware of. The European Commission itself has one e-translation tool that is available for public administrations, NGOs, SMEs, public institutions, including an API, a web API, allowing for machine-to-machine translation. If you search for e-translation European Commission, it's a strong, powerful tool. Myself, I consider it to be better than Google Translate. I use it all the time. That could facilitate in some cases. Thank you.
I'm going to ask Daiga and Alina just to give their reactions and also to say, I have notes, I'll share them with you around the conclusions, because just to explain as well that the next steps for us at the Peak Solutions Project end is that Alina and Daiga's report will include what we've agreed today as next steps and outcomes, and then that report, the final version, will be shared with all of you. So I will share my notes with you.
Yeah.
If you can read them, I'll write them up. I might write them up for you too. Anyway, would you like to give your feedback to what you've heard?
Yeah, thank you. So I really appreciate what we did today, because I think that here in this room there's a lot of energy to move forward. But one thing we may be missed and we have to stress, it's childcare. Yeah, this is one more issue actually we have a little bit developed and to mention, because this is very important. And what relates further actions and these projects and the coordination, we would also like to stay as part of the project, because you know what in Latvia, what there is let's say how we deal with implementation. So actually we are very good in planning, in plans, in thinking about stating what we want to do. But then we lack resources in implementation. And actually as university, we could be, let's say, helpful, maybe resource if there is implementation, so that we stay somewhere the side and look how it is implemented, because for us it's very interesting. As I said, we represent health management division, and actually cross-border health management also is a part of health management. So it's our interest, of course.
Perfect. I was actually going to ask and suggest as well that if you establish this collaborative for the region, that our colleagues from the university would also stay connected with that. One of the recommendations that we made as part of the patient mobility study was the establishment of these collaboratives, which are ad hoc, not overly rigid in their structures, but just collections of stakeholders in border regions who want to work through solutions together in terms of those health ecosystems. One of the very important cornerstones of that is the expertise and the data and the research, and making sure that what you're doing is linking with international best practice on the clinical side, but then also that you can draw on data sources, health economics data and that sort of thing. So if you're willing to be part of that, I'm sure that would be a huge plus, and I can't see anyone disagreeing. Are we all happy to keep Daiga and Alina's team involved? Great, thank you. And again, I think there were other areas of care that we did hear about today. I think pediatrics is one of those things. If you're talking about prevention, the 0 to 5, the perinatal care, so antenatal care, looking at reopening your maternity units, looking at potentially community midwifery network for the cross-border area, for care at home, all of those things that can happen if you have a maternity unit somewhere in a region, but there's a lot of outreach that can happen as well. And again, how that the maternal health agenda and the women's health agenda links with the child health agenda. Again, there are lots of innovations, particularly in places like Finland, in rural regions. So you're absolutely, Maria, you're going to be a really good resource to this group because you have that insight as a clinician into how things work in rural Finland and across borders. So I think you've got so many assets in the room and outside of the room, because we have our NCPs and Andreta and all of that experience. And by the way, I should also say, in sympathy to the National Health Service, I worked in the National Health Service at home for 10 years, so I know what it's like to be the bogeyman as well, and to be blamed for everything when you're trying to actually make the system smarter and you're trying to work with limited resources and you're trying to make things more efficient. But what I would say to any of the national health people involved, these collaboratives will help you to create solutions that will make your systems smarter and make sure that you're able to do as much as possible with the limited resources that you have. And it also allows you to make a strong case for new resources, because you're proving that what you're doing with your resources already is as efficient as it possibly can be. So that would be what I would say to the national health people. I'm going to just leave it open for some final comments, and then I'm going to hand back to maybe Martin to say a couple of closing words from ABR's perspective, Ricardo from the Commission, and back to Vilmars. So anyone else from the floor want to say anything or comment? Yeah.
Man pētniecēm vārds, jūs tā kā apskatījāt tādā kontekstā, ka Latvijā ir pamata veselības aprūpē un pilna apdrošināšana tādā kontekstā, to pieejamību. 4 gadi. Es tā kā nekur, varbūt es nepamanīju.
Varbūt jūs nepamanījat, ka tas, kas ir ierakstīts finansēšanas likumā par pilnu un nepilnu apdrošināšanu, ir paredzēts, ka tas ir spēkā šī gada tikai jūlijā, bet šobrīd ir spēkā grozījumi, ka tas nestāsies spēkā arī šogad jūlijā, būs vēl vēlāk. Tā kā mums nav dalītais gros, mums ir viens gros visam iedzīvotājiem.
Skaidrs, labi, paldies.
Any more questions? Some suggestions? No, I think then we can close our conference for today. Only we have small thank you to say to our research team. Yeah. Our chair. Yeah. Conclusions.
Yeah, is
Sorry.
that okay?
Yes, conclusions. Sorry.
I don't want to introduce
I rushed forward.
interrupt the presentation. Martin and Ricardo, do you want to say some final?
Sorry.
You okay? Martin?
Here? Yeah. Well, not that much. I cannot contribute with a smart recommendation right now because everything has been said. But we take home several things. First, when we look at the different stakeholders present here, this says a lot. So clearly, it's not only something that has been defined by the experts or by someone in Brussels. It's that we can confirm that there is not only a need, but also the will to implement a solution here in place. This is very important. The second is that I was not aware of the level of implication of the national authorities, health system, insurers, etc. Now we see that there is, at least they have listened, and even they have put some comments on board. I think this is quite mature. And then I would like just to guarantee that, of course, during the life of B-Solutions, the project is fully at your disposal to exchange, to come here to support, and even like this. But even also, if you consider that, just to put in the maximum, if you consider that we need a political debate, it's something that can be also arranged. Everything is possible if we have the obstacle, the need is clear, the potential benefits and the stakeholders. But even though, as an Association of European Border Regions, we hope that before B-Solutions is finished, this will be solved, and then we will have a success case. But if by any chance this is not happening or is not complete, I would like to guarantee that the association will be also at your full disposal even afterwards. I don't think it will be necessary. I think we are talking about probably a success story. But in any case, this goes to the heart of our association and the members which are behind. Because if we are able to solve the issue here, as I told before, is not only going to be an asset for the citizens here, it's going to deliver a very interesting message to Brussels and to the capitals. So we will, let's say, we will push for more solutions like this as long as we have more. So it's a question of quality too. So I thank you very much, and I hope that we will have the opportunity even afterwards to have some informal exchanges. In any case, you have the contact data of ABR, Katrina, mine, our colleagues working in B-Solutions there in Berlin, and we are fully at your disposal. Really, thank you very much.
Thanks, Martin. And I'd just like to reiterate that we're on this journey with you. We'll also see if we can connect some of the story of the collaborative to the Interreg program, and if we can help in any way with that. If you need us to come and attend online meetings with you or anything like that, just please keep me in mind. I am the contact point for B-Solutions on this process. And I think also, as Martin said, it's about friendships. I mean, making borders work is about friendships, and it's about friendships between regions, and it's about us all having a common experience and sharing what we know with each other to see if anyone can, you know, crack the code of things. So it's a collaborative symphonic experience that we're all part of. So Vilmars, I'm going to hand back to you, and I say thank you to you all as well today.
Yes, so basically I want to conclude, I think, the two main steps that we need to do forward. First are these administrative questions about how we can use integration of both e-health systems, how we can move forward with translations, and how we can actually get this as a working system for Valga hospital doctors and Valka area general practitioners, so they actually use this as communication tool. We have tried this before with like an email tool, but this hasn't really worked. At least I haven't heard that somebody has been using it. But I think this is now something good that we can work on, and it doesn't take any outside help, any national level decisions for us to do this. But number two, of course, is this existing agreement that we have. It ends in 2026. I hope and I believe that numbers will tell. Numbers are clear, and we need this prolonged after 2026. And of course, our colleagues here have identified critical services that would be needed. We need to look at specific services further on. What could we include in a further agreement similar to this one we already have, so we can move on with specialist consultations with some other diagnostics that are specifically to solve a problem. From the very beginning, I always thought that this is a no-brainer issue, and we should just open the hospital completely up to Latvian citizens. Of course, as time has moved forward, I have become less, let's say, more realistic, and this we need to move forward in small steps. But definitely, we can't go back. Our people need this, and we just need to move forward with new services and work on the existing infrastructure, how to make it more efficient.
I think that's it. Thank you very much to all of you from me, and to the research team, and to Vilmars, and to Zana and Toms, and also thank you to Valga municipality for being here. I know you've been very quiet, but that you're here matters as well, because this is the partnership of the place. So thank you for coming and being supportive. I'm going to sit down now.
Paldies visiem par saturīgo dienu, un cik sapratu, šodien ir radīt labvēlīgu augsmu mūsu kopīgam mērķim, atliek tik čakli strādāt.
Paldies vēlamies teikt mūsu zinātniecēm, pētniecēm no Rīgas Stradiņu universitātes. Thank you to our research team. Daiga Dūdele, Daiga Behman un Alīna Dūdele. Also, we would like to thank you from all our hearts for coming such a long way, to Mr. Martin Guillermo Ramirez and Ricardo Ferreira. Thank you. But the most of all, thank yous are coming to Catriona Muller. Thank you very much for being in each step of this development of our project. Thank you with us. Thank you. And thank you everyone for coming today, for participating in our conference. This is maybe feels like small step for us, but it's important step for us. So thank you very much.